بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen, distinguished guests, esteemed speakers and participants. It's my honor to welcome you all to the first session of the Saudi International Medical Education Conference 2024. My name is Hussein Aghili, a professor of medicine and former Dean, College of Medicine, Jazan University, and editor-in-chief, the Saudi Journal of Health, Research and Practice. I am honored and privileged today to serve as moderator of the first session titled Challenges and Opportunities in Health Professions Education in Saudi Arabia. This session brings together thought leaders and experts and address critical issues shaping the future of medical education in our region, focusing on program accreditation, international collaboration and culture, and cultivating a culture of lifelong learning. As a nation with a rapidly evolving health care landscape, Saudi Arabia has made significant strides in medical education, including pioneering efforts in accreditation, promoting interdisciplinary collaboration, and fostering lifelong learning. Today's sessions will explore these crucial elements with insight from exceptional lineup of speakers. Our first speaker is Dr. Hussein Al-Hussein. Dr. Hussein Al-Hussein is accomplished radiation oncologist and an esteemed leader in health care quality and accreditation. Dr. Al-Hussein holds dual subspecialty fellowships and in head and neck radiation oncology and CNS stereo radiosurgery with a robust clinical career at King Fahd Medical City in Riyadh. He is a fellow of the Royal College of Physicians of Canada, and has earned a Master in Health Management from McGill University, showcasing his unique blend of clinical and administrative experience. Dr. Al-Hussein has played a pivotal role in shaping health care accreditation standards in Saudi Arabia and as the Executive Director of Accreditation at Saudi Commission for Health Specialties. His work has driven transformative changes in interprofessional collaboration and institutional accreditation across the kingdom. Today, Dr. Al-Hussein will present accreditation as a driver for interprofessional collaboration in Saudi Arabia in health education. Dr. Al-Hussein will give his speech as a recorded speech, and I invite our colleagues to start the lecture.
It's indeed of my great pleasure to be with you today at the Saudi International Medical Education Conference, and thanks to the organizing and scientific committee of the SIMEC2024, and many thanks to our colleagues from the Saudi Society for Medical Education and Jazan University, and our colleagues participating at the conference. We are going to be briefly addressing how does the Saudi Commission Accreditation act as a driver for interprofessional collaboration in the Saudi Arabian health education and training system. Next. The Saudi Commission for Health Specialties is targeting its efforts to have a community that is healthy through competence that is led by passionate and compassionate, competent healthcare practitioners. Next. This is accomplished through training, establishing and accrediting training programs through the Saudi Commission for Health Specialties with our partners at the healthcare institutions, training in the Saudi board training system, where we do have over 180 training program that's enrolling 20,000 plus trainees. And we are looking for to assure quality of training through the Saudi board training. Next. Regulating the health professional practitioners and capability building of our healthcare practitioners is the main focus of the Saudi Commission for Health Specialties. And this is happening either through professional practice regulations and for the professional practitioners, or for the training, whether it is for the specialty training or the continuous professional development. Next. Next. The Saudi Commission for Health Specialties have been working through the regulatory framework to govern training and accreditation supervision over the training programs that are delivered by our colleagues in the training centers, where there had been 3 levels of the training programs, where, as you know, the Saudi Commission for Health Specialties, through the Saudi board training, we are overseeing health professionals training for all healthcare disciplines, for physicians, dentists, pharmacists, nurses, and allied health professionals, and with over already accredited in the training centers as 180 specialization that are accredited in over 2,000 training program in the training centers in over 640 training sites, with 20,000 plus trainees who are registered at the Saudi Commission. It had been for the past 12 months, kind of a large transformation where we are seeing the training programs into 3 levels. There are the first level, which are considered to be high risk, high stake, first entry training programs, which are right after the bachelor degree. These are like the diploma and the main specialty programs, where this is very much regulated and strictly regulated through the Saudi Commission, with either establishing these programs, approving it, establishing the scientific committees and councils, scientific committees and councils, the curricula, and having the accreditation standards approved, delivered, surveyed by the Saudi Commission for Health Specialties, where the matching, admission, examination, whether it is through the summative assessment or the ongoing continuous assessment that's going on for the trainees, all that's been kindly, strictly regulated through the Saudi Commission for these programs that are considered to be the first entry programs for the healthcare practitioners. I'm not going to talk into the details of this regulatory framework. We already had one dedicated forum to discuss this back in October 18th, 2023, but just kind of overseeing where the Saudi Commission is putting through that framework to make sure that there are not all programs are looked at the same way. The one size does not fit all, where the first level programs, these are, as we mentioned, high risk, high stake, high volume, are looked in a way that's more kind of centrally regulated at the Saudi Commission, with the delivery happening in the training centers. Where we go to the second level training programs, which are the main subspecialty. Again, it is regulated with the Saudi Commission, with it's considered to be the main subspecialty that are required for programs, for example, adult cardiology, nephrology, these programs that are very well known to be main subspecialty, it's looked at almost the same way as the first level, with certain variations that are shown here, with the recommended compliance to the training capacity, and the formative assessment is approved by the ITC at the training center level, and having the summative assessment has to be happened through the Saudi Commission. The third level training programs are considered to be the main, or actually the area of focus competence subspecialties. These are regulated through the Saudi Commission with a set of templates, criteria, minimum requirements to establish these programs, but the central regulation, the central control, the central oversee of the Saudi Commission does not have to be to the degree as it is in the first and the second levels, where most of these programs, as areas of focus competence, subspecialty programs, they are in other systems or training systems across the globe, are fully overseen by the hospitals and the universities, and there's almost no rule at the regulatory authority in each one of these countries. We're here at the Saudi Commission, we are putting up the framework, templates, the minimum requirements for establishing these programs, approving it at the training centers and at the Saudi Commission, having the requirements for the training program committees at the training centers to act like the scientific councils and committees, and having the curricula approved at the level of the institution training committee, having the internal review standards approved at the institution training committee, and the internal review is going on and overseen by the training program committee and the institution training committee. And all the way through the details here, where the trainees are assessed by the training centers, and then they get the certification by the Saudi Commission and by the training centers jointly. Next. There are over 45 new training programs that are being established as we speak. We have 180 specialization that's already accredited and already having trainees enrolled into them. And we have over 45 programs that have been established. There had been humongous amounts of increment of the requests to establish these programs on the third level, which is very healthy, which is uniquely addressed at the Saudi board training compared to other countries where these are completely under the hospitals and the universities. So we are having further quality assurance of these programs while giving the training centers and empowering them and enabling them to be able to act and perform their role to oversee training in a very regulated manner in collaboration and in partnership with the Saudi Commission. As we know, or as we do have in a nutshell, like we have over actually 109 training centers that are institutionally accredited. These are overseeing 652 training sites. We do have 218 programs that had been under the Saudi board. 180 of them are already accredited in the training centers, and almost the rest are already almost like talking about almost 40 programs are already under the establishment phase to be launched soon. Some of them are first, second, or third level training programs. We do have 29,000 accredited training seats and counting and increasing year by year, and thanks to our colleagues from the training centers and the training resources that have been put forward to the Saudi board training. As we have briefed earlier, we have over 2,000 training programs that are accredited in the training sites and training centers across the Kingdom of Saudi Arabia, Kingdom of Bahrain, and Dubai United Arab Emirates. Out of these, there are 228 diploma programs for all healthcare disciplines, and 1,136 training programs for the main specialties, and 766 programs for the subspecialties, whether it is a main subspecialty or a focused competence subspecialty. all these programs, all these training centers, training sites, we are engaged to ensure training is not only for training is for all healthcare practitioners. And interprofessional and interdisciplinary training and education is the mainstay and is actually the distinguishing factor of the Saudi board as one of the leading boards globally in postgraduate health profession training. Next. This is just a quick brief of the distribution of the training sites across the 5 training sectors. Next. Oversee of the training centers, sites, programs, and training seats across the Kingdom of Saudi Arabia, in Dubai, United Arab Emirates, and Kingdom of Bahrain. Next. And you see that the training capacity, accredited training programs are rising as we go. And this is all in support of the healthcare system. And again, it's looking for the healthcare professionals at large, not only for certain disciplines over the other. Institutional program accreditation survey visits have been maintained virtually and on-site, and over 1,000 accreditation survey that are delivered or actually conducted every year is to make sure that there is a clear compliance to the institutional and program accreditation standards, and to maintain the accreditation of the training centers and programs. Next. It's just a brief of the switch from on-site accreditation surveys to virtual in 2020. When we launched the virtual accreditation surveys, we had the target of the first year that had 10% of our surveys done virtually, then 50% of the surveys done on the second year virtually, then over 90% of the accreditation surveys are done virtually in the third year, and we have been able to manage through. By 2023, we have over 90% of our accreditation surveys are done virtually. This is from December 2023 or late 2023. Then in 2024, we have been exceeding 90%. Next. Institutional accreditation surveys, the second version had been launched in January 2024. It had been announced in January 2022. It does have 132 institutional accreditation standards, and 88 of them are of ATR 0, which are mandatory and has to be in full compliance. 57 of them are of first category essential training requirements standards, which are mandatory, but you need to keep full compliance of over 90% of them. And 7 of these standards are highly recommended. That does not negatively affect on the accreditation decision. Next. All these standards are looking into the healthcare system at large. It's not looking at training. We're preparing the healthcare practitioners to be able to perform their role as active experts in the healthcare sector. And this is just a nutshell of the second version of institutional accreditation standards and the amendments that have happened in the institutional accreditation standards, whether these that are related to the patient rights and making sure that we enhance the concepts and principles of patient rights for our trainees, the patient experience, the model of care, empowerment for the implementation of the model of care, the modern model of care as part of Vision 2030, healthcare transformation. Making sure that our national health insurance targets are achieved through the institutional accreditation standards, and there have been some of these standards that are, 3 of them that are ensuring that we fully enable the national health insurance through the training. and linking the training output and outcomes with institutional accreditation standards, and whether it's related to the assessment, the final assessment, or the practice, and any issues that happen in the professional practice of those graduates of the training, the study board training, where it's been recorded and implemented and linked with the institutional accreditation decision for the subsequent years. Having two standards that are looking at the mobility of the trainees from training site to the next, and a few other standards related to or amendments to the standards and further improvement and development of these standards, whether the weights, the phrasing, the distribution, and so on and so forth. Next. It's the 10 standards that are looking at the model of care. I'm just going to keep the slide for a few seconds. I'm not going to go through them and go through them one by one, but just to keep it. Next. 5 standards looking at the patient rights and making sure that the principles of patient rights have been clearly addressed through training. Next. 2 standards related to the patient experience of the patients in the training centers towards the experience they go through with the trainees while they are receiving care. Next. 3 standards related to the national health insurance and how the training and the trainees be able to enable the implementation of the policies and the involvement of the national health insurance system. Next. 3 standards related to the training outcome and outputs. Next. 2 standards related to the mobility and the commute of the trainees between training sites to make sure that we ensure trainees' safeties and patient safeties. Next. Reviewing the weights and phrasing of some of the standards to make sure that our trainees are actively engaged into projects looking at patient safety and quality improvement. Next. When it comes to the program accreditation standards, we do have program accreditation standards already are established for 190 programs. So including 10 of the newly established programs have already been approved, but yet to be accredited in the training sites. There's 33,000 program accreditation standards that have already been approved and already been implemented for the accreditation surveys when it comes to the training programs accreditation. There are around 5,000 training program accreditation standards that have been established for the newly established training programs. Next. Just looking at the status of the institutional accreditation for 2024. Next. And for the program accreditation status for 2024 with our colleagues in the Executive Administration of Accreditation. Next. I'd like to thank our partners, strategic partners in the Saudi Commission with various institutions. Next. Without the very robust collaboration and partnership with our partners in various sectors, and one slide cannot include all our partners, but talking about the sectors at large, this would never have been possible, and would like to celebrate together the achievements. Every single day we see our Saudi board graduates provide the service at the highest standard in the most compassionate and safe and competent manner. This is the most rewarding to all of us and with our partners. Thank you so much, and it's been indeed a great pleasure to be among you today, and we'll be greatly looking up to the discussion. Thank you so much.
Thank you very much, Dr. Hussein, for your valuable lecture. Actually, we will keep all the session discussion to the end, but because Dr. Al-Hussein is talking to us from distant through the Zoom, we will open for him a short time for discussion. So the floor is open for any question. If any of the audience have any question for Dr. Hussein. Please. Do you have organizers? Please, the mic. Here.
السلام عليكم ورحمة الله وبركاته. دكتور محمد النعمي, جامعة الملك خالد. Dr. Hussein, thank you very much for your elaborate lecture about the accreditation and the efforts that you have done on this area. I would like to ask you about, you have mentioned that the Saudi Commission for Health Specialties is interested in implementing accreditation and standards for interprofessional education, which I think that's a very good initiative. So please, can you elaborate on this so we will understand more in depth your efforts in this area? Thank you so much.
Thank you so much. I highly appreciate it, Professor, for your query. So the Saudi board training programs, when you look at the curricula, when you look at the accreditation standards, is looking at training our physicians, dentists, nurses, pharmacists, and all other allied health professionals in their respected specializations, keeping into account the fully integrated mean of care delivery. For example, I'm just gonna address some of the standards that we have highlighted that linked with the model of care. The modern model of care looks into the holistic way of delivering the care from virtual, primary, secondary, and tertiary, and looks at integration of all the healthcare disciplines together. And it does encourage, if you look at the accreditation standards and look at the curricula, the integration between medical, nursing, pharmacy, and others. When you look at the version number 2.0 of the institution accreditation standards, you look at our trainees have been, it's actually one of the standards that the training center should encourage our trainees to be engaged into building or developing, reviewing, and optimizing the integrated care pathways. The integrated care pathways is looking at the care for the patients, let's say for a general surgery resident, as an example, who would do the surgery, and he would be encouraged throughout his or her training to make sure that they are part of building these pathways that takes care of the patient to the next level with the integration with their colleagues from nursing, pharmacy, and others. If you look at the model of care 10 standards, you will see that very clearly translated into the training. Go to the curricula. So we're just going to take that journey where we are trying to encourage that interdisciplinary. The curricula does not address and speaks out to delivering the care and training our physicians to do the care without the integration with our colleagues from all disciplines. The distinguishing factor in the Saudi board training is that we don't have training only for medical programs. If you look at the royal colleges and others, they're in charge of certain disciplines, some of them for the physicians, others for dentists, others for nurses, and others. In the Saudi Commission, we do have, in Saudi board training here in Saudi Arabia, we do have the integrated training programs for all disciplines. That gives us the edge where we design our programs, curricula, accreditation standards of the training centers. We keep into the account that you are in the middle of a team, multidisciplinary team, and interdisciplinary training and education is at stake. I hope that does address your query, Prof.
Okay, thank you very much, Dr. Al-Hussein, for your contribution. I have a word to the floor to my respected audience. Please keep quiet because the hall is very noisy. If somebody have a personal chat, he can go to the exhibition, he can spend time or have a coffee. Just we need to concentrate on the scientific content. The next speaker is Professor Ahmed Al-Rumayyan. I'm very honored to introduce him. He's a trailblazer in medical education and a respected pediatric neurologist. Professor Rumayyan currently serves as Dean of the College of Medicine in King Saud bin Abdulaziz University for Health Sciences at Riyadh. His academic and clinical contributions has profoundly influenced the field of pediatric neurology and epilepsy. Dr. Rumayyan is a fellow of the Royal College of Physicians and Surgeons of Canada and holds PhD in medical education. His research focused in aligning medical curricula with the Saudi medical framework, enhancing medical licensure process, and improving the clinical reasoning among students. He is deeply committed to advancing the standards of medical education in Saudi Arabia, bringing global best practice with local needs. His talk today is about the future of Saudi medical education guidelines, the Saudi Med framework. Welcome, Dr. Rumayyan.
شكرا جزيلا دكتور حسين. السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. First of all, I'd like to thank the organizer to invite us to this conference, and I would like to while we're waiting for the presentations, I was in a conference yesterday about neonatal neurology. And it's about all the diseases of neonates and looking after the management of those diseases. And the aim is to prepare those neonates to be a competent personnel in the community. And at the same time, our presentation here is to prepare our students to be really a competent physicians looking after those persons. So my talk today is about, can we have first slide, please? This is what I want. Thank you. Next slide. So my talk today is about the future of Saudi medical educational guidelines, Saudi Meds. Next. Have a next slide, please. Anyway, I'm going to talk about the, of course, introduction, Saudi Meds, as well as, can I have, yeah. Can I have the mic off here? Because there's a mic here. Yeah. It's not changing. Okay. So starting with the introductions about the competencies. What is competency? As we see, it is an observable ability of the health professionals, which is related to specific activities which integrate knowledge, skills, and attitudes. The other kind of approach, actually, to this competency is what you call it competency-based education, which is the instructions, the grading, the assessments, and the reporting, which is based on the students demonstrating that they have to learn the knowledge, the skills, and the attitude. What is competency-based medical education? It's a lifelong learning, longitudinal learning. The students will be evaluated on how they apply actually the knowledge to the clinical situations. And this is the cornerstone of my talk. Now, the outcome-based education is focusing everything you're doing on the curriculum, on the education, on the assessment, the evaluations, for all students or trainers to be able to do successfully at the end of their learning experiences. It's a spiral model where you start with of course, the graduate outcome, and so this is the graduate outcome, and then going back to the process, what you call it, in putting actually these competencies into the curriculum to be integrated as early as possible. Now, what is competency? It's about, like in history, it's about like me, which is, you call it apprenticeship. Like in Arabic, it's called talmada. And I think it is still here, it's still applied in the medical education. And one of the things that we think in medical education is that one of the influential, what you call it, way of teaching is role modeling. And I think apprenticeship is reflecting actually role modeling. It's all about knowledge, of course, where the students has to pass the tests based on the knowledge. It's about also performance. It is an evolving concept. It's about all blended performances, or all blended what you call assessment, including those what you call it OSCEs, which is observable skills. Now, it can be trained during the medical curriculum, but the students have to be able really to integrate this for the management of their clinical skills. We know the Dreyfus and Dreyfus model, starting with the competencies, with the novice, advanced beginner, and then competent, and being proficient and expert. Just to give you a background about Saudi Meds, we do have 38 medical schools. About 30 of them is public. They have varieties of assessment and instructions methods. There has been a national call for having a competence-based medical education in Saudi Arabia over the last 20 years. And Saudi Meds, which is the Saudi Medical Directives, was really established in 2017 by the Saudi medical deans through a subcommittee which worked really hard in developing this. And I see Professor Mohammed Al-Rukban or Professor Abdul Ghani is there, and also Dr. Rania Zaini was among this team, and Dr. Hayani, who did really well in terms of putting actually all this together. And the aim was to ensure that the minimum learning outcomes for all medical colleges across Saudi Arabia. And it was at that time, it was recommended by the Education, Training and Evaluation Commission for all medical school as the minimal, what you call it, a standard for medical schools. The subcommittee went through the looked at the international models like CanMeds. They looked at the other models like Scottish doctors with all the competencies for undergraduates. Looked at in the US, looking at what you call it, the commissions for general medical education. And you can see those competencies like patient care, medical knowledges, practice, interpersonal or communication, professionalism, and system-based practice. And then there was also in 2011, a published what you call Saudi future doctors, and these are the competencies that at that time. So based on all these literatures, the Saudi medical directives framework were established in 2017. And this is the themes, the 6 themes of Saudi Meds, starting with scientific approach to practice, the patient's care, the communication, the community-oriented practice, communication, research, and professionalisms. It has also a sub-theme, and it has what you call it, 17 key competencies. And these key competencies are the one that put here as what you call it, a program learning outcome for medical schools to be as a guide for them. And these are the 17 ones. And those 17 are the minimal, what you call program learning outcome, although the colleges were given the autonomy to add to this program learning outcome. And it was published recently. Now, what is important after this framework is the implementation of this framework. And the Saudi Dean's Committees mandate a working group for Saudi Med implementations. We did about 17 workshops to elaborate as a guide for all medical schools to implement Saudi meds and to integrate the Saudi meds in the curriculum. And of course, for the implementations to be effective, it has to be reflected at the level of the Saudi medical licensing exam. As you know, assessment drive learning, and also national accreditation process. So we can say evaluation also drive learning. The key elements, which is important for the implementations, we thought that it is the curriculum design and governance, systemic approach to curriculum mapping, longitudinal integration of the competencies, faculty development, and also the change management. And I can't forget the leadership also support to integrate this. And this is one of the models that we used for alignment of the competencies with the benchmarking with the CAN-MEDS, the course learning outcome, even at the level of the session objectives and ultimately the assessment. And this is also the phases that went through to integrate the framework into the curriculum with the curriculum alignment planning and then alignment implementations and alignment assessment. And this is a dashboard which start with the learning outcome and then the performance KPI and then outcome. So you can see that along the dashboard, the alignment which start from the program learning outcome, which is the program learning outcome from Saudi Meds towards the assessment. The second version of Saudi Meds also is a working group from Saudi medical deans. The aim is to systematically refine the Saudi Meds competency framework through doing a application of Adelphi methods to address the evolving needs of Saudi physicians and aligning with the latest advances in healthcare. One of the first phase here is to evaluate the competencies of medical education, which we did it as systematic review, and this was really done and published. The second phase is to outline the current implementation process, identifying the major challenges and factors that empower the implementation of Saudi Meds. And then we go to what you call suggested revision. The step 2 was to see what is the current status of the implementation among the colleges in Saudi Arabia. And there is, I would say, increasing number of colleges that adapt this implementation in the kingdom. And the manuscript, it's in writing phase right now. One of the suggested changes in the second version of Saudi Meds is the leadership, the technology-based practices, the community-oriented, as well as other competency like sustainability development. Ultimate with the second version is to have a refining of Saudi Meds competency framework, which is a systematic revision using Adelphi methods to address the evolving Saudi physicians' needs and community demands, as well as the health care. And as you heard, there is a recent publication from the Education and Training Evaluation Commissions by publishing what you call the Jahaziyya, which is the KLOs, addressing the minimum curriculum requirements, the key learning outcomes, and building the curriculum map, including the teaching, learning, and strategies. And that Jahaziyya, or the KLOs, was really developed by NCAA in cooperations and coordinations with different entities. And this is from their good documents, such as Saudi Commissions for Health Specialties. They consist of knowledge units, and it was based also on Saudi Meds and the Royal College of Physicians and Surgeons in Canada, like CAN-MEDS, and Accrediting Council for Graduating Medical Education. The essential knowledge units is the English, biology, and chemistries, the general, what you call it, knowledge units based on the scientific foundation, clinical skills, community health. You can see that there is an overlap between this as well as Saudi Meds. And these are the key learning outcome. I'm not going to go in details, but there are 14 key learning outcomes. I think if we go and map between Saudi Meds and the KLOs of the Education and Training Commission and the interprofessional educations, we can see that there is an alignment between the Saudi Meds as well as the KLOs of Education, Training and Commission, as well as the interprofessional educations. So you can see that there is an alignment, and of course there is mostly an overlap between those competencies and what looks like the WHO interprofessional educations or the competencies for interprofessional educations. What is important question here is, how do you improve the medical education in Saudi Arabia? Whatever framework that we're using. And the other question is that, how do we implement this at the nationwide level? And are we going to use what you call it, the traditional content-based program by selecting the content and then go to the process and the outcome? Or more ideally is to start with the outcome and then go to the input, what you call it, a selection of the students, and go to the process, which is the learning activities and the assessment strategies. The successful transitions towards what you call it competency-based medical educations, it's actually a continuum between education, training, and practice. As we know, there is the entrustable professional activities that aim to graduating medical students that should be entrusted to do without direct supervisions on day one of the residencies. And this was developed by Oli Kate as a framework to connect the assessment of competencies with the reality of medical professions. There is a lot of efforts to apply this IPE at the undergraduate level. And as you know, the Association of American Medical Colleges, they did define the professional activities that every medical student should be able to do, and they came up with 13 APAs for entering residencies, and these are the 13 ones, starting from gathering histories towards performing skills, giving perform general procedures, as well as into the management. This is a proposed kind of framework. Whatever framework we're applying, I think even if we start with the key learning outcomes or Saudi Meds, and having those what you call required competencies, and at the same time we have this what you call it the clinical situations, any clinical situations, whether it's taking history, examining the patients, it has to be based on the observable what you call professional activities in the middle, taking consideration what you call it the trustable professional activities. We had the experiences at our college in applying this at the intern level, starting with what you call history taking, with making it as like a formative assessment, satisfactory or unsatisfactory. We did a program for this where the admin, the evaluated, the interns roles has to be detected, and it is automated through this automated system just to make sure that those activities is distributed to all interns. How about the future? I think there should be a nationwide collaborations between the education, training, and evaluation commissions, between medical Dean's committees, between Saudi Commissioner of Health Specialties, and other health care, as well as the public. And as you know, there is political and educational reasons. The ethic and the NCAA has the authority, of course, to implement this. Saudi medical deans, as a recommended body, of course, there is an overlap between the Saudi Meds as well as the KLOs. And I know the medical schools are positioned into what looks like between what you call it, the health care as well as the university and educations. So the mandate, I call this Saudi Working Group for Competency Implementation. And I think this is the most important thing. Whatever framework we're using, it's the implementations that really matter. And the delegates should be from all those stakeholders with the following mandate to ensure that the alignment between the competency framework at the level of the undergraduate schools, students, and also at the level of Saudi medical licensing exam. And those groups to propose a coordinated approach towards evaluating the implementation process, and then to develop a guide for all medical schools. Of course, to involve the faculties, we can't forget faculty development, students and administrative staffs, to be aware about those framework. Of course, we have to respect the autonomy of each medical schools and evaluating those implementation process. Of course, strong leadership support for change towards this competency is really needed. And all medical schools to align specific learning goals of each learning outcomes to the competency-based framework. And the question is that how far can we trust the students to take care of the patients on his or her own? And it has to be also multidimensional assessment methods to align with the competency framework. And ultimate goal is to graduate competent physicians that really provide a better patient's care and meet the challenges of the medicine in the 21st century. There is a need for aligning with the Saudi Meds and KLOs, of course, and also the current format of Saudi medical licensing exam is an applied clinical knowledge. As you know, it doesn't include the clinical competencies. We need to have a practical clinical skill exam in the format of an objective structured activity to assess all aspects of medical competencies. We don't only focus mainly the knowledge. And we did a study about...
1 minute, 1 minute.
We did study this two slides, thank you. We did studies about aligning the Saudi Meds with the Saudi medical license exam, and we find that the blueprint of Saudi medical license exam is partially aligned with the themes and domains of Saudi Meds. This is the suggested framework to have the Saudi Meds, whatever the KLOs of the NCAA, the national framework, the course learning outcome, the objectives and delivery, as well as the assessment. And I will leave you with this slide, which is very important slides. We have to make sure that the planned curriculum, which is the structures of the activities that we are teaching the students, as well as the experiences, which is the clinical experiences, has to be mapped both together with the, what you call it, competency framework. So in conclusion, a nationwide implementation of the National Outcome Competencies frameworks, the all medical program is really the cornerstone of applying this framework. There is a need for national collaborations. We don't want to work as independent bodies. We have to be in collaborative group and developing a curriculum mapping approach will really facilitate the exchange between different actual medical schools in Saudi Arabia. Saudi medical license exam used to be accreditation process to be aligned with the competencies. So the blueprint of that Saudi medical license exam has to reflect really the framework. And as I said, the national aim is to improve medical education in Saudi Arabia to provide a better care for the patients and the community. Thank you very much.
Thank you very much, Dr. Prof. Rumayyan, for your talk. Our next speaker is Professor, questions after. At the end, we'll have the questions. At the end, we'll have the questions for all speakers. Now, our next speaker is Professor Hussam Hamdi. He's a luminary in field of medical education and distinguished pediatric surgeon with over 40 years experience. Professor Hamdi has been instrumental in transforming medical education across the Middle East. He has established and led several medical colleges in Egypt, Bahrain, United Arab Emirates, and Qatar, setting a benchmark for innovative teaching and curriculum design. As a visionary in medical education, he has authored over 70 highly cited publications, pioneering advancement in program accreditation and medical education reform. Professor Hamdi has been recognized internationally with numerous of awards, including prestigious Knight of the Order of Academic Palms from France and fellowship designation for the Royal College from the Royal College of England. Today he will share with us his insight on ensuring quality and effectiveness in health profession education through program accreditation. Please join us in welcoming Dr. Hussam Hamdi.
Thank you very much, Professor Hussein. I would like first to thank University of Kazan for inviting me to contribute to this wonderful conference. And I always remember in 2010 when I was also here in the SIMEC. And what a great change which happened during this last 14, 15 years in Kazan and in Saudi Arabia. I thank Professor Ahmed Rumayyan of his presentation, because a lot of things which I'm going to talk about are looking in what was presented, but maybe in a slightly different way. The main theme of this conference is about interprofessional education, and it should be always, as we've discussed several times, and practice, and not only IPE and practice or collaborative work. And we all know that communication is a core competency in healthcare profession, education, and healthcare in general. But empirical evidence about the effectiveness of how we teach and how we assess communication is low and weak. We don't have evidence. And there is a continuous problem of communication which is happening, whether during the education or in the practice. And in this presentation, I will be arguing that communication is not only a skill. It is more of a complex system. It is a wicked problem. And it should be viewed through the lens of system thinking. Let me jump immediately to how I see medicine in general. Medicine is a social science. It is about people, societies, the human interaction, and it is inseparable and embedded in a rapidly changing healthcare system. So the healthcare system change and it drives the education. And believe me, all what we are doing in medical education will change within the coming few years with the AI, the disruption which is taking place. All the accreditation will change. We have to be looking at the ecosystem around us as a medical school or as a health profession education responsible for that. So health professional education is inseparable from the healthcare system of the country, the economic, political, social, and cultural systems. All these systems are around us, and they are affected by us. They affect us, and we contribute to it one way or another. And the problem of communication in healthcare and health professional education is not about the technology or the curriculum or how we teach it and how we assess it, but it's this complex relation in this rapidly changing environment. Both environments are changing. So we are situated in the middle between two systems, the educational system and the healthcare system. And medical education, health professional education is unique. And you have to understand both the two systems. You have to understand the culture of the healthcare and of the education and respond to them. And this is what is called the wicked problem. I am repeating this word wicked problem, but I will explain what is a wicked problem, which I've learned it from management actually. So a wicked problem is a complex, it is ambiguous, it's dynamic, more than one stakeholder, very sensitive to the context. It has no clear boundaries and no single root cause and no final solution. All the time it evolves and it changes over time, and that's why it will change very soon and difficult to predict or evaluate its outcomes. So this is where we are. And communication in health, which I'm saying is a wicked problem, and argue that we need to move from communication skills. Even in the title of my presentation, I removed the word skills, and I will explain why. Or as a course in communication, to a continuous, holistic, multidimensional, multi-system reflective program. It's interesting, you will find in your institutions that the College of Medicine is teaching communication skills, the College of Nursing is teaching communication skills, the College of Pharmacy is teaching communication skills, and so on, but they don't communicate to each other. And they don't know what the others are doing. So this paradigm shift, there must be a paradigm shift. So coming now to system thinking, it is a philosophy, it is a mindset. Facilitate an individual thought process to see the interrelation of the different parts of the system. And systems, they communicate. Within the system, intra-system communication, and between the systems, inter-system communication. And when you have a problem in communication, in practice, or it is just the tip of an iceberg. It is the tip of the iceberg. And that's the visible part. But we are not conscious, or we don't see what's the other systems which contributed to this below the level of the water. So visualizing the seen and the unseen drivers and consequences of interaction in any situation. Think about it. This is system thinking. So, what are the barriers for effective communication in health profession education? There are many barriers. It's multicultures, the patients and the learners, the different health professionals, the doctor, nurses, the pharmacist, and others. Multi-system healthcare and educational. All this is reflected in these barriers for effective communication. The students, the professionals, the systems, and the patient in the middle, leading to failure of communication. And communication is integrated, if you go back now to communication, and represented in all competency domains, which Professor Ahmad has presented it, at different phases of health profession education, undergraduate, postgraduate. And it should not be perceived as a separate entity or a course. This is Professor Van Dolen and has indicated that from Maastricht, I think. Now, when you look at the competency domain which was presented, the different competencies already made and other competency systems, and looking at communication. But before that, what is the problem with, there is a problem with competency-based education. I started competency-based education actually using the word competency in 1979. 1979. And even the APAs, I called it at that time optimum physician performance. So there is nothing new. But if you look at what's the problem with competence-based education? Competency overlaps. You cannot separate knowledge from practice, from ethics and professionalism. They overlap. And the challenge, how to translate and implement and assess these competencies. And you'll find that communication is core in all these competencies. You'll find it in the Saudi Med under communication and collaboration, in ChemMed communicator, in ECGME interpersonal communication, in GMC, so on and so forth. So we just present it in a different way. Even in UAE, also they have UAE ChemMed and so on. When you go to the EPAs, which were also presented, you will find communication approximately in maybe 10 out of the 13 EPAs. All this gather history, commend, discuss orders, provide oral presentation, give or receive patient handover, all this, they have element of communication. So how you will separate communication in teaching it or in assessing it from all these EPAs if you are using the EPAs. So the broader picture of the scope of communication, we are used as patient doctor, patient health professional. So this is a physician-patient-family interaction. That's a common model. Communication with difficult patients, maybe you are using it, different culture, gender, ethnic, and language. Communication with other professional, IPE. Public with the media, it's another way of communication. Communication at a distance, all this digital and telemedicine, and communication with other systems, with the government, the healthcare, the insurance, and policymakers. Now the doctor, the graduate, he has to know how to communicate with medical insurance, how to order, the coding, and this is a way of communication, systems. Even communication with self-reflection. I think it's another way of communication and coping with stress. And now communication with AI, which I think Dr. Hassanein is going to talk about that. I wanted to, I like this. What are the patient expectations? In simple words, the patient is asking not to treat me, but heal me. Keep me safe. Do no harm. Be kind to me, all the empathy and so on. Engage me, shared decisions. By the way, this is, I think it's a projection. I'm not saying it's wrong, but this is, it just appeared. So how to communicate this to the patients? We need to think, heal me. So why the outcomes of teaching and assessment of communication are inadequate? Because it is considered a skill. We teach it like, one of the contributions, we teach it like other procedural skills, following a reductionist approach, how you start, how you, in the middle, how you end, how you give feedback. So it became a skill, and I will talk about the checklist and the problem of the checklist, which we teach the students use this checklist. So communication is considered as a soft skill. I've always been saying it's a hard skill. It's not a soft skill. We have difficulties and inconsistency in how to teach it and how to assess it. And there's always tension of teaching the correct balance of biological sciences, all what we do, and situational ethics, which include and judgment. These are not my words, these are in the literature. And the empirical evidence of its effectiveness is small and confidence in the result is low. This is recent publication by Gilly. So the common practice focus on the spoken doctor-patient interaction with a broadly counseling approach through role play and skill labs. To Abdulaziz, I'm not against simulation, but I'm just putting it in perspective. We teach them in the simulation lab with a simulated patient, an actor. The student is acting, and the faculty evaluating the acting. That's what is happening in simulation. I understand that we do this before exposing them to the patient. I mean, this is a concept. I have a different views about that. I believe that learning has to be in the real world, in the real work environment, combined with simulation. And this is the best way of teaching. You may say this is more advanced. No, it can start early. It depends what exactly. And if you put things in a conceptual, theoretical framework, which I like it very much, I like the community of practice theory of Lava and Wagner, for example. And learning occurs through social interaction with the community of practitioners. How they talk, how they walk, how they decide, and so on. So the message here is embed the learner in the workplace, the junior to become the junior member of the tribe. He will learn. And if you want, as again Professor Ahmad has presented the Dreyfus and Dreyfus model, I modified it a little bit and trying to relate this model, as you can see, to the competency at the point of exiting. And I call it proficiency-based progression, early introduction and reinforcement, taking them from novice to advanced beginner to competent, so on. So going back to system thinking for teaching communication skills and reflective approach, it is important when you take them as a novice till they are becoming competent or expert, to expose them continuously in a spiral way, in a helical model, to the different systems, the patient systems, the provider systems, the students' systems, the healthcare systems. So they have to come across these systems and be in touch with them to see the holistic approach of related to communication and healthcare. That's why a reflective model for teaching communication in health professional education practice, I start by exposure to the workplace, and then simulation, and then back to workplace, and back and forth. So the students, it's important to expose them to the real life. What is happening there? Even if it is just going and talking with the patient in year one, forget about the disease, just a patient which has an event in his life, and just talk with them. But they will see what's happening around them. Then they reflect on the experience, whether it is a small experience or it's bigger experience for a short time or long time, and they share these experiences together. Then bring the simulated patient, and then back to the real patient. So all these systems are like that. So focus on the patient lives rather than the patient bodies. The problem in assessment of communication is that we break down deconstruction of the good consultation or communication or any competencies because we want to measure it. So we deconstruct the competency, while the competency, it's in its totality. It's wrong to deconstruct it. Yes, I've finished. Yes. So why we are deconstructing to measure it, to come with KPIs? But subjectivity and objectivity in assessment of communication in the clinical one, the more holistic one is, the more subjective the judgment. But subjectivity is not a sin. It is more realistic, it is more valid. And that's why we have applied, again, I think Dr. Ahmed has mentioned that, we have developed an assessment which we call it readiness for practice examination. And it's a barrier, they have to pass it before going to the final exam. Integrating all the competence, different competencies together in a holistic approach. I can discuss it in more details. So in summary, I think communication is a core competency. It is a core competency that should be taught and assessed through the lens of system thinking, recognizing its multi-systems nature. The linear design in teaching and using simulation and asking for assessments needs to be more holistic, culture sensitive, reflective, and practiced in the workplace environment as early as possible. Realism.
Time over.
Thank you very much.
Thank you very much, Professor Hamdi. Thank you. Okay, actually we need to interrupt the session for 5 minutes. We have the public relations. They will honor the speakers of this session now, and I invite the somebody from public relation to talk. Muayyad, I think. Go ahead. نعم.
حفلنا الكريم ندعو الآن كلا من سعادة رئيس الجامعة الأستاذ الدكتور محمد بن حسن أبو راسين، ووكيل الجامعة الأستاذ، وندعو كذلك سعادة عميد كلية الطب بالإنابة الدكتورة زينات خرد، وسعادة رئيس الجمعية السعودية للتعليم الطبي حسن الزهراني، لتكريم المتحدثين في الجلسة الحوارية الأولى، وهم الأستاذ الدكتور أحمد الرميان، وندعو كذلك وكيل الجامعة للشؤون الأكاديمية الأستاذ الدكتور محمد عريشي، الأستاذ الدكتور حسام حمدي، الأستاذ الدكتور عبد العزيز بوكر. دكتور جيرالدين بيجون. والآن مع الجلسة الحوارية.
شكرا جزيلا لسعادة رئيس الجامعة على تكريمه للسادة الضيوف والمتحدثين في هذه الجلسة. We resume our session. It's my pleasure to introduce our final speakers for this session, Dr. Geraldine Bugene and Dr. Albine Moser. Actually, Dr. Geraldine, she visited this university several times before. She is a managing director of She Collaborate at Maastricht University School of Health Profession Education, which is abbreviated as She. Dr. Bugene is a leading figure in global health profession education, known for her expertise in evidence-based student centers and problem-based learning methodologies. Her work focusing on enhancing healthcare education in both lower and higher resource setting, with a strong emphasis on innovation and sustainability. She, as the founder of She Collaborates, Dr. Bugene has led numerous international projects to strengthen healthcare education systems. She has worked extensively with universities, health ministries, and donating organizations to redesign medical curricula, establish skills labs, and promote community-oriented education. Her global initiatives has empowered institutions to implement sustainable, high-quality education practices tailored to their unique needs. Also, it's my honor to introduce Dr. Albine Moser, is a distinguished professor of and researcher in health and interprofessional education. Dr. Moser is a professor of applied science at Zug University and an associate professor at Maastricht University in the Netherlands. Her expertise lies in shared decision-making, autonomy in chronic care management, and fostering the interprofessional collaboration in healthcare education and practice. Dr. Moser earned her PhD from University of Maastricht, focusing on autonomy and competence in patients with type 2 diabetes treatment or treated in nurse-led clinics. Her work has since extended to include leading research groups in autonomy and participation for chronically ill individuals, and developing interprofessional education frameworks using healthcare and social works. With numerous high-impact publications, she has advanced the understanding and of collaborative approach in patient care and education. Together, they will present to us cultivating a culture of lifelong learning in health profession education. I welcome both of them, please. By the way, Dr. Albine will be with us distantly on Zoom platform, and Dr. Graldine, she will be with us moderating or helping in this lecture.
Shukran Yazian, Professor Hussein. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Ahlan wa sahlan. أنا لا أتكلم اللغة العربية معلش. So I have to continue in English. And that will already be a barrier in the communication. I listened carefully to your talk, Professor Sam Hamdi. But unfortunately, we have to do it with an English, and I'm borrowing that language because we are in the Netherlands speak Dutch. So if there is any collaboration or barrier in communication, you can ask afterwards, and I'll try to explain slowly. There is a challenge in this meeting that we will do the presentation online. I have the easiest part. I'm here with you. I can meet old friends from so many countries, not only from the kingdom, but I met already dear friends and colleagues from Yemen, from Sudan, from Oman, Pakistan. It is wonderful to be here, and it is a pity, Albina, that you cannot be here presential. But I think you can do a good job online, and I'll give you the floor now. I'm going to sit back in my chair and listen to you, and at the end I can see if there are questions, and I will come back to the stage then. So enjoy the speech of Dr. Albine.
Geraldine, I hope that the audience can understand me because I cannot see you anymore because I have shared the presentation. The presentation is not about lifelong learning, it's about background theory and context of interprofessional education and collaborative practice. And let's see if you can, yeah. I again have a picture of Dr. Geraldine and of myself because I thought you cannot see me, so at least you have a small picture, and in the background you can see Maastricht University. And where are we from? Dr. Geraldine and I, we teach and work in the Netherlands, and especially in the very south of the Netherlands. And the very south of the Netherlands is very specific because it's hilly. We are in the Dutch mountains. And maybe you can see it in the big screen. On the left you have Maastricht, and on the right it's Heerlen. So there are two red dots. This is where we work. And yeah, I have come digitally, and Dr. Geraldine is physically in Jazan, and we are very happy that we can show you the European perspective on IPE. And I will talk about the background, the theory, and the context. And about the background. In Europe, it all started in 1983 in the UK. And there, the first interprofessional conference happened in Anfield. And it was organized by a social worker, by a nurse, and a GP. And in 1987, CAPE was founded, and CAPE is one of the pioneers of interprofessional education worldwide. And one of the founding fathers are John Horder. He is a GP, and maybe some of you know him. He is also considered the architect of the Portuguese primary care. And the other one is Professor Hugh Barr, and Professor Hugh Barr has been president of CAPE for many years. And he is still alive, and he still thinks a lot about IPE. And from the European start, it took the way to globalization. In 1988, the first worldwide report, Learning Together in Work Together for Health, was about multi-professional education. And I think the signature publication was in 2010, the WHO framework for action and interprofessional education and collaborative practice. And in this framework, they write about the challenges, the shortage of health workers, the fragmentation of healthcare system, and the complex health issues. And when we look ahead, or when we look now, I think they really had a good view on what will happen in healthcare. But the framework also promises certain things, that collaborative practice will strengthen our health systems and patient outcomes. And to really effectively provide collaborative practice, you have to have interprofessional education. And actually, higher healthcare institutions should deliver practice-ready, collaborative practice-ready healthcare workers. And this framework, I think, very much explains it, what it is all about. You should always start from local health needs, and the local health needs can be very different. The local health needs in the south of the Netherlands, for example, is very different than in the Amsterdam area. Because, for example, in the south of the Netherlands, we are a rural area, and we have a lot of elderly people. Actually, 25% now here in the south are 65 years and older. And we also have a shortage of health workers already, but also a fragmented health system. And the fragmented health system asks for interprofessional education. And those who educate interprofessional should be aware that the students should graduate as collaboration-ready professionals, because if they have learned how to collaborate, they will also bring it in practice. And this, in the long run, will strengthen the health system, but improve health outcomes. And you have some studies that really shows that collaborative practice improves health outcomes. And it all depends on the local context. Without context, you cannot do interprofessional education / collaboration, because you always have to start from practice to really educate interprofessionally. And I will give you an example. We know, for example, for the future in the Netherlands, the cause of death number one is cancer. 50% will really suffer from cancer, cardiovascular disease, but we also know that in the future, 1/3 of elderly people will suffer from dementia care. And we know, for example, that the population will be in the future be 30% inhabitants with migrant background and 60% Dutch. So this is the context we actually have to deal with, and we already have to prepare our workforce in the Netherlands. And when you look at this perspective to the Arab context, you probably have other challenges that can be addressed by collaborative practice. And in this report, they also defined collaborative practice. It's an ongoing partnership between professionals from diverse backgrounds working together to serve healthcare users and families. And in this report, in the WHO report, they also define interprofessional education. All occasions when two or more professions learn with, from, and about each other to improve collaboration and the quality of care. And the important thing about this definition is that it is the CAPE definition. So actually, when this definition used has its origin in the United Kingdom. But this definition also implies that learning has to be differently. It's always interactive. Learning through social participation is the heart of IPE. It also requires learning and teaching across professionals, and it requires a lot of flexibility. It asks for a common language, trust, respect, and especially a collaboration attitude. Next, I would like to give you a short introduction to theories. And again, I start with Hugh Barr. And Hugh Barr already in 1988, he says we need 3 kinds of competencies to be able to collaborate. These are the common competencies all healthcare professionals share. And earlier this morning we heard about the Saudi CANMEDs, but for example, communication with the patient, it's not something from the medical professions, it's also from the social worker, from the nurse, it's also for dietitians, occupational therapists, etc. The complementary competencies are those competencies you bring in because you are an expert. A nurse is an expert in nursing, a medical specialist is an expert in medical care. A dietitian is an expert in nutrition, and collaborative competencies so that you can work together. You need all 3 to be able to collaborate. So this was Hugh Barr in 1988. And when I look at some competency frameworks, I took them from Australia, USA, Canada, and also the IPEN competency framework. IPEN is the European Interprofessional Education and Practice Network, and they have different competencies frameworks, but you can also see that culture, national priorities impact on which competencies. And what is really, really interesting is that a cycle, it's not a linear process, but it's cyclic. And it shows the necessity of integration and interdependency of different professions. And what we really, when you look at them, the common ground is teamwork, communication, role clarification, shared values and ethics, and conflict resolution. And many of these values, actually, I have already heard in previous presentations. So what about the context? And I really would like to look at context and culture, because looking at the developments, this will become more and more dominant in interprofessional education, because the workforce in Europe, but also around the world, is moving. And this also means that somehow next to interprofessional competencies, we might also want to acquire cultural sensitive competencies. But the most important thing is the healthcare context. What are the health needs of the local, regional population? If you don't know the health needs, you can never have IPE that is related to reality. We also need to know about cultural diversity of the target population, because culture very much determines the needs people have. And we have to consider urban and countryside because the healthcare structure in cities is different than on the countrysides. What we need to consider is also the scope of practice because we have a local diversity on the availability of health professions. We know that specialities are centered in the cities, and we know that on the countryside, more general health or health professionals are more general in their practice. We need to consider the scope of practice because it changes. The role of health professional changes. I give you an example. In the Netherlands, we discuss the substitution of tasks, especially, for example, from medical professionals to master educated nurses. We experience what I call a lot of e-nursing, that patients do not come to the hospital anymore, but they have e-consultancies with special educated nurses. And we always also have to consider roles, responsibilities, and legal matters. I'm sorry. The next one is about context is the professional authority. I call it the white coat. The white coat is a symbol, but we know from literature that there is some hierarchy within the healthcare systems. So, and it's very important that actually those that are high in their hierarchy are aware of it and are supportive to those who feel lower in the hierarchy. Also, patient advocacy. One thing about the definition of interprofessional collaboration is to serve the benefits of the patients and family. It means that the patients and family should be able to voice their own goals, they have their own needs. And the next one is leadership versus and decision making. And what you really see in interprofessional collaboration, leadership is different from decision making. Decision making is very often an authority, but leadership means somebody follow somebody because they want to. It's not functional. It's really that they feel that somebody can be meaningful. And the thing is also leadership in interprofessional collaboration should be shared leadership. And gender. We are aware that it's still in healthcare, it's very much integrated, especially, for example, in nurses. Most nurses are in Western countries are female, but we also know from an international perspective that much more men are in leadership position than women. And we also have to consider the culture of individualism versus collectivism. In the Netherlands, for example, we have an individualistic society, and in Arab or in the Middle East, it's more collective, but it impacts on group consensus, but also how you handle interprofessional contexts, how to avoid conflicts, for example. And when we look at international, there are actually a lot of international networks on interprofessional education, and I start on the right corner, CAPE. CAPE is actually a UK network, but many of the networks are based on relationship with CAPE. For example, IPEN, the European network, was based on a European grant to set up a knowledge infrastructure across European countries. And you also have NIPNAP, these are the Nordic countries, and the Canadian, but you also have on the right the ANIC, Arab Network for Interprofessional Collaboration. And I hope when that you can kind of unite and you can really share the knowledge, ideas, and experiences. And maybe you are a member of the Interprofessional Global, we call the Interprofessional Masterminds, come together and they try to influence education of the global health workforce. But what is the take-home message I really want to give you from my experience is when you do IPE, you really need to get to know each other first. You really need to know who is the nurse that I'm going to develop IPE, who is the dietitian, who is the social worker. Also bring all the necessary professions at the table to design, test, adapt, implement, and evaluate IPE. And I hope that maybe there are not only medical doctors, hopefully there are also educators from other disciplines participate in this conference. Otherwise, it really remains monodisciplinary. IPE is always interactive. There is little lecturing. Yesterday in the workshop, which Dr. Geraldine and I provided, we have heard very interesting examples of interactive IPE. Choose your IPE topic that is related to all professions involved and to the local context, because when you do it at school, they will recognize it when they are in their internship, when they are in their placement. And you really should train IPE educators interprofessionally, because then you really you foster an interprofessional attitude. And actually, I want to also spend some words on the painting. It is done by a student, and this student actually tried to paint the ideal picture of IPE from the viewpoint of a child with multiple handicaps. And I think it's so nice how students in their second year think about IPE. So thank you very much. I will unshare my presentation. Dr. Geraldine. I cannot hear anything, but...
Yes, I'm here,
Oh.
Dr. Albine. It's a long
Oh.
way from my seat to the to the Speakers Council, but we got 5 minutes because we have a tight schedule and we are going a little bit beyond. So if there are any questions, I would like to ask and try to answer them. Are there any questions for Dr. Albine or myself? I think there is a question in the back. Do we have a microphone or how do we do that? There is a question in the back. Do we have a microphone?
Assalamu alaikum. Thank you very much for the presentation. And I just want to ask simple question that what strategies can be employed to overcome the power dynamics and hierarchy in interprofessional teams. This is a quite big challenge for us when we are going to implement this philosophy in real world.
Thank you very much. If I understood your question well, it is about how do you deal with power and hierarchy while you also need to collaborate. And that is a kind of situation that makes collaboration very hard. It needs respect and equal approach in order to break the barriers and to really collaborate. Albine, did you get the question?
Yes, and I agree what you say, because it's always a matter of collaboration, because those who are in power should be willing to decrease the power difference and to encourage the others, and those who feel they are not so much in power or have less authority, they really need to have empowerment strategies. And when you look at healthcare within the different professions, you also have a kind of hierarchy. It's, for example, well described that social workers feel very low at their authority ladder, and medical professionals are very high. And these power dynamics, people very often learn already at schools, and they are reinforced what they see in practice. And to take it away, actually, it really you need to talk about this with those you want to collaborate, to really take it away and what it means. The thing is, very often, if those who are in power have to relinquish power, it's very hard for them to To empower, it's really to depower yourself when you are in the authority position. And that's very hard. This is what I have observed.
And that means that you have to start training at an early age of the students, but also be a good role model in the working place. Thank you very much for listening. I understood that the lecture is also recorded, so you can always go back to it. And if there are any more questions, you can come to me afterwards. Thank you very much.
Ladies and gentlemen, thank you very much. At the end of this session, I would like to thank our respected speakers and audience for their attendance. Unfortunately, this session was delayed a lot at the beginning. We started by 11 instead of 9, and also we had some interruptions. Unfortunately, I have some messages from the organizers to conclude, omitting the discussion session. And I know that many of you have burning questions for the audience, but I advise all of you to keep it to the networking meetings and sessions outside the hall, and have them or discuss them with the speakers. They will be with us for today and tomorrow. Thank you very much for your attendance. Thanks to respected speakers for their contributions, and have a great day. Thank you.
In a few seconds, we'll proceed with Dr. Abdulaziz Boker talk, inshallah. The deans of Faculty of Medicine in Saudi Arabia need to go, all of them, to the restaurant because they have a meeting in the tower, in the Jazan University tower. We just want you to be aware of that. After that, we will take a break. After Dr. Boker talk, we'll take a break for 15 minutes for lunch. If anyone want to take a lunch or prior time, because we are late on the program, and sorry for that. Now, Dr. Shazia Iqbal will lead the second session. We'll start with Dr. Boker. I will be honored if Dr. Abdulaziz Boker, Prof. Muhammad Hassanin, Professor Yawar Hayat, and Professor Fadil Saitako, they will talk in this session. So we'll start now. Dr. Shazia, please proceed.
Rahim, good afternoon, everyone. It's absolute pleasure to welcome all of you to this SIMEC 2024 conference. I'm really thrilled about this session because we are going to talk about innovation, different approaches, especially in enhancing interprofessional education. I am Dr. Shazia Iqbal from University of Buckingham, United Kingdom. My background is Obs and Gynae, but I'm very much passionate medical educator. I'm chair for Saudi Society for Medical Education and chair for learning and teaching at University of Buckingham. I'm very much delighted to moderate this session. We have a series of speakers, very thoughtful leaders in their respective fields, bridging innovation insights like simulation, technology, artificial intelligence, to develop leadership and collaboration. As healthcare professionals, we understand that collaboration across discipline is critical to improve patient outcome and fostering innovation. So today's session is really very interesting. I want you to participate and actively engage with our speakers. Our first speaker of this session is Professor Abdulaziz Boker. He is going to talk about integrating simulation in interprofessional education. Professor Abdulaziz Boker is professor and consultant of anesthesia and critical care of medicine at King Abdulaziz University, Jeddah. He is also a chairman of Department of Anesthesia and Critical Care and medical director of Clinical Skills and Simulation Center at this university. Professor Baker is pioneer in advancing simulation-based medical education in Saudi Arabia and has contributed significantly to the development of interprofessional education through simulation. Very warm welcome, Prof. Abdulaziz. Mic is yours now.
Thank you very much for staying late for the program, and I'm really honored to okay. In the coming 20 minutes or so, I'll be talking about the use or our experience in Saudi Arabia integrating simulation in interprofessional education. As you're aware, this is a big topic and everybody is talking about it. We started at many colleges in Saudi Arabia using simulation. And we're just waiting for the presentation to be on the screen. I'll keep this to the time. So basically, the slide is not moving. Am I moving it or are you moving it? So everywhere, everybody is talking about quality. Everywhere in the healthcare system, as we've heard, quality is the word of the day. And simulation center and equipment are available everywhere in Saudi. So I will be talking about the expanding role of simulation, various techniques, not technologies, that's used in simulation, and how to increase it in day-to-day use. Those are my three objectives that I'll be briefly touching on. Why simulation? One way to do it, our experience in Saudi Arabia, and form of simulation that are available now and coming to be more available. Why simulation? There are lots of reasons. Unfortunately, Prof. Hamdi left here, but learning on patients is not acceptable. Especially when there is high-risk procedures. You cannot teach people on the patients. Patients stay less in hospital. There are a lot of learners. The numbers increase. And instructors are busy in the private. We know this not only in Saudi Arabia, everywhere. So there are other competing interests on teacher time. There are a lot of things you cannot. As I heard Prof. Hamdi and everybody say, clinical. Yes, how can you teach airway management or cardioversion on patients? I wish you can, but you cannot. Simulation make that. How can you examine sensitive area for 400 students? You can't. Real life, simulation will not replace real life, but real life cannot replace simulation. You can. Genital assessment, how can you teach rectal exam to a large group of patients for all lesions? Very rare things, anaphylaxis. Students will never have it in real life observed. In simulation, you can create it. Also, there is never risk to the patient, students, healthcare system. It's not about safety for the students, safety for the whole system. And you will see in Saudi Arabia, this will be more. Patient Safety Center, Ministry of Health, Sibahi, everybody will be asking about the use of simulation because this is a worldwide phenomenon. You can make the condition known or unknown. Different than real life. If students did something in real life, you have to interfere. You cannot leave him do mistakes. In simulation, they can do mistakes, and the most important thing, can they recognize their mistake in the next step and recorrect? You cannot do this in real life. Simulation, you can make them do mistakes, and then autocorrect, give the wrong blood, what they will do next. Of course, they have to interact with power share, different persons, and we know inside every person, different personalities. The drunk, the angry, the agitated. You could always create this in simulation every time. Also, in real life, you cannot record. In simulation, you can have evidence for portfolio, for progress. So there are a lot of things that you can do simulation. Worldwide, it's been used as real life. This is an example of emergency medicine programs. Either you do this in real life or in simulation. Of course, to err as human, the report in 1999, people dying because of medical error because of performance is equal to 2 jumbo jet crashing every week. This is in the States. Of course, here, we have less, you know. I think we have worse, but we maybe not have the data. So since 2002, the chairman of the American Board of Internal Medicine, it's very imperative to do more with simulator. It's legal, ethical, professional to do. In Saudi Arabia, I will show you, we worked. This is a now integrated mandatory part of residency training for senior, junior across the kingdom. Now we have boot camp for anesthesia residents across the kingdom. Doesn't matter where you go in Saudi Arabia, and this was recognized by Royal College of Canada for the International Educator Year of the Award in 2014 for integrating, and that could be done everywhere. So one way of doing it, I'll just reflect on our experience at King Abdulaziz University, which is an example, how did we start the simulation program. So again, these are the numbers that there are a lot of enrollment and shortage in healthcare. Very clear, we had a lot of students, but we're afraid of training them. So we started a clinical skills center focusing on excellence, competence, and clinical competence and excellence. This is vision, mission, goal, to use simulation and technology to improve learning. And we use all types of solutions, AV system, part task, simple solution. We started with emergency module, then anesthesia, then other modules. We started from medical college, then nursing, then allied health, then all other health colleges in the university. Then we went for the hospital staff. Then we went for Ministry of Health. Then we went for the Saudi Commission. In all, we use the same theories that used in education and simulation to develop programs. We developed more than 500 different workshops using simulation for residents and trainees. Also, we provided more than 300 workshops for train-the-trainers, basic and advanced, trained more than 2,000 trainers nationally and internationally. This is our course done in Russian. If the voice is there, it's the same train-the-trainer course we've done in Russia just before the COVID. And you could see people, doctors, nurses, they work together to advance this. We have made the expert program. Now we have 11 or 12 simulation-based educators. At the Clinical Skill and Simulation Center, we always placed a lot of resource on data collection and rigorous continuous reporting and feedback. In the first year, we had 800 sessions, 2008, 2019, we had 35,000 sessions. Also, we calculated the hours. In 2015, we finished the first million hour. 2019, we finished 2 million contact hours. We shared our experiences in terms of publications, and this is what I call all academics to share their experiences in all forms of simulation. Also, we worked hard to spread this in the media, public media. We had a lot of focus on television interviews and campaigns with conference and without conference. We arranged 3 major conferences in Saudi Arabia with over 1,000 audience. Now there's growing number of people interested just to create the move for the need for simulation. As I said before, we work to integrate simulation in national programs. We increased enrollment from about 100. Now there's 600 residents in the national program for anesthesia using simulation to prepare anesthetists for and these are the sessions that we use across the kingdom. Also, we help to create the society, which is this existing and vibrant Society of Simulation in Saudi Arabia. Also, a lot of technical reports how to operate. Also, always to keep in mind their international standards, the Canadian standard, American standard for quality in simulation. Also, the AMI with the Aspire Award of Excellence in all these domains to make effective use of simulation. We applied for all these in 2016 and 17, and we were the first one center in the region and internationally to get the 3 awards in the same year, 2017, and this is the great team that we got the Aspire Award of Excellence from the European Society of Medical Education in 2017 as one of 5 centers around the globe to have it. Finally, forms of simulation. Of course, is healthcare safe? This is going into Himalaya on this side. On the other side is traveling on the airplane. Healthcare, medical risk is in the middle. So we really have, going to hospital today, working with teams today is like crossing the road. It is very dangerous. So there is a lot of room that we could transfer from anesthesia and blood transfusion safety to move to nuclear and commercial jet. So there a lot of work can be done in improving medical risk. Of course, if we were successful, that's great. If you fall, your friends will do this for you. As Professor Hamdi always talk about simulation. Prof. Hamdi, like this, you know, when you fail in projects, somebody push you like this. Of course, simulation is everywhere. Going to space and coming back to Earth is all simulation. Going through the same cycle, plan, do, check, act, plan. It's the whole, of course, they use it in flights, in actions, boxing. So those are the different roles. Verbal role, standardized patients, you could use for team or individuals. Part tasks, now there are over 5,000 different tasks that you could use. Everything you think. Now 3D printing, you could just do also human parts. You can use it for training or actually for healing. Those are 3D printed. I think they finished. There's something finished here.
Time is finished.
No, I still have 9 minutes.
Yeah.
So I think simulation and integrating, I don't know, so simulation forms, including using of different type of virtual mannequins, also using high fidelity simulation, can be used to prepare team and individual. And شكله هيشتغل. I just want to show you one video of us using high fidelity simulation in real life. طيب هي كلها صور. So now, I mean, we can see a lot of products in which you can integrate simulation and AI on the patient picture. So you could have CT scan with Google Lens. You could see it actually in the patient. So artificial intelligence could, I think, improve even bringing simulation to real life. As Prof. Hamdi said, you could always take from workplace to simulation. And sometimes now you can bring also simulation to real life. You cannot differentiate very soon, I think, from, you know, now the pilots, if you see them flying the airplane, it's the same environment when they simulate. And I think very soon, with the technology in place, you can create this in healthcare. في فرصة حصلها ولا just conclude? So I wish to show you the videos in which we prepare teams, how to communicate even for complex services in the hospital. But I will just focus and conclude my talk that simulation is here to stay and grow. It has a lot of reasons why it's sound, because it focuses on performance. It can overcome many obstacles in real life. Real life, simulation will not replace real life, but real life cannot replace simulation. It focuses on performance and outcomes. Intensive commitments from stakeholders. The simplest thing is to buy equipment. The hardest part is to make them work. So you need a lot of faculty, because faculty need a lot of preparation, psychological preparation. Everybody is giving feedback. In simulation, the focus on reflection, teaching, debriefing, and learning. Thank you very much for, I had pictures for the people who helped me. I'm very happy to be able to give this talk. And sorry for the technical glitches with the system here. And if you have any questions, I'll be happy to answer.
Thank you so much, Prof. Abdulaziz. And we shall take 15 minutes break. All questions will be taken by end of this session. So we shall take 15 minutes break and then we'll start our next speaker. So see you after 15 minutes. United Kingdom as an expert in clinical biochemistry and medical education. Currently serving as advisor for educational affairs at King Abdulaziz University. He has led numerous initiatives in incorporating artificial intelligence and technology in medical education. Professor Hussain is also certified practitioner with Education and Training Evaluation Commission. Very warm welcome to stage, Professor Hussain.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. First of all, I'd like to thank the organizing committee for giving me the opportunity to be here in Kazan for my second time. The first was in 2010 and also in the SIMEC. Today, inshallah, I'll speak about adopting innovation and technology in healthcare with the emphasis on AI as a model. This is my learning outcomes or objective, which is about analyzing educational transformation, exploring the AI application in medical education, and I'll start to introduce customized GPTs as a way to leveraging the use of AI in education, especially medical education. The last but not least is to plan for strategic implementation for technology and the AI in medical education. And this is my content, starting by changing landscape in medical education, key AI application, customized GPT, and the future direction. Let's start by changing landscape of medical education. First, I think all of us agree about rising the student number in all universities, including health sciences specialty. Among with this increase in size, there is limited resources, and I mean here in resources, physical and human and even financial resources to cover the increase the number of students. With complex content and a huge amount of data and content to be covered or to be explored in medical education. And also we are dealing with a new generation, whatever the generation or millennium generation, with different expectation from us as a medical educator and different expectation from their schools. Also we have certain challenges, include, as we mentioned, limited resources, the variability of teaching quality between different educators, lack of personalization. Sometimes you need some sort of adaptive learning or personalized learning strategies for students, and also the practice education gap, especially between basic science and the clinical science. Opportunities from technologies and AI. Actually, AI and technology provide a lot of opportunities for improving medical education, including enhanced learning through personalized learning landscapes and platform, gives the way to efficient assessment, either through standardizing assessment or automating grading, or even helping in developing question bank and constructing different test items. And the last is to personalize the education or adaptive learning. Let's in few 2 or 3 minutes introduce an introduction to AI. AI simply is the process or the science of computer scientists try to imitate or simulate human intelligence in all its aspects, including the cognitive part, and I always say that in cognitive part, they try to imitate it in Bloom's taxonomy, starting from recall, understanding, analysis, application, synthesis, evaluation, and even creation, but we have some concern about creation. It is not only about cognitive part of our brain, it is also related to the special sense we have in our laptops and mobile Siri, which can hear and speak to us. Also AI application can analyze images and generate image, so it also can see. And even now, the smelling, by giving the computer program a large amount or data about odor, and it can develop and generate new odors. Also related to psychomotor or physical, we have the robotic surgery, our colleague in surgery, and the driverless car, monorail. All of them are working by AI. Beside AI, we have two important terms, which are machine learning, in which computer scientists train a machine or program on a large amount of data through algorithm, and based on this training, the AI application can start a conversation with us to generate data, to generate text, image, video, audio, codes, games, etc. Another subset from machine learning is the deep learning, which is a more complicated term in which computer scientists were inspired by the neurocytes and dendrocytes, which are in the form of a network from different dendrocytes connected together by chemical transmitter or electric impulse. The same is deep learning. It is a layers of machine learning which is connected together through algorithm and through different sets or network of machine learning. And the best example of deep learning is that of a recommendation system, in which sometimes we in social media find a recommendation to a friend, or in Noon or Amazon we find a recommendation to certain product based on the product we had previously purchased based on our preference. ChatGPT, which started in November 2022, is a chatbot and is a member of a chatbot like Perplexity, List, SciSpace, Gemini, Microsoft Copilot. It is a chatbot. Chat because we can chatting with it in automatic way, bot because it is automatic. GPT is G for generative, B pre-trained because it is trained on a large amount of data, and the transformer is the type of its model. We have three types of AI. The narrow or weak, but it is not weak, but it is narrow because it only work on a certain and specific task, like the machine learning, which were developed for predicting of certain disease or predicting the risk of certain business issues or whatever. We are in the era of generative AI that can generate different types of text, as we mentioned, image, videos, audio, games, software. The new era, which is the general or strong artificial intelligence, in which computer scientists want to not only imitate, but only to become like the human brain that work not only in one mood, in multi-mood. So it can think, help in the problem solving, decision making, and at the same time can hear, can speak, can move like the human. This era is just started and it is evolving, and I think in few years, maybe few months, we'll have some examples of artificial or strong AI. Before we start this session, the official start, we need to ask ourselves, is it safe to use AI in general? This question will bring another question. So once we start, we need to ask ourselves another question. It is important to us that the information come from AI is true. So if we ask AI for a vacation planning or whatever, it is not important to be true. But in our case, in medicine or in research, it is important to have a true or right information. So we need to ask ourselves another question. Did we have the expertise to verify the correctness of this information? If no, so please, I ask you, come with me. It is unsafe to use AI in our work. But if it is yes, so it is khalas, we can use it. No, we need to ask ourselves another question, which is, can you take the full responsibility of any mistakes, including legal, medical legal, academic, whatever? So if it is no, so it is unsafe to use it. If it is yes, so we can use. No, it is possible to use it. For this reason, you know, in the chat GPT, there is a box below the page. ChatGPT may make mistakes, so check important information. It is like smoking is harmful to health. And for this reason, Sam Altman, who is the CEO of OpenAI, the company which produces ChatGPT, said it is a mistake to be relying on ChatGPT for anything important right now. And Sam Altman, as we said here in Saudi Arabia, يعني واحد من أهل البيت. So it is in the company and they said this. So please, for using any ChatGPT, we need to ensure and verify any information come from it, whatever the application. What's the application of AI in health professional education? All of us, either an educator, physician, or researcher. So AI can help us in all these fields. This is just a list of using AI. AI can help us in curriculum design, teaching, learning, assessment, quality accreditation, data collection, data analysis, writing report, administration, management, empowering academic leadership. And I think we can list one or two lists like this if we can ask about how you use AI. But I'll focus, inshallah, about using AI in curriculum design, teaching and learning, assessment, and research. And I have one slide for using it on health care services. For curriculum design, it is a process starting by using the AI for data collection and data analysis about student performance and pattern. Then we can make a personalized GPT or personalized AI application based on the performance and this pattern. Then start the process of adaptation. I mean by adaptation that the program or AI application can change the questions or can change the piece of student pathway based on his or her performance. Then continuous improvement after evaluation of the program or the application. In assessment, a lot of things we can do with AI in the field of assessment, including assessment automation, standardization, generating question bank, and constructing different type of assessment can be done. And also we can use it in feedback. AI can help us to generate or develop rubric, and based on this rubric, it can grade or mark student assignment and can give them feedback based on their performance. Data analysis of assessment, including item analysis, assessment of the achievement of learning outcomes can be done through AI. And also adaptive testing, in which the test is adapted on the performance of a student, and based on this, the difficulty of questions will be increased or decreased based on student performance. The last but not least is to generate different type of questions. And for making adaptive learning platform, again, we need to start with initial assessment and then customize the learning pathway for different students, and dynamic content delivery based on student to progress, and the last is to continuous adaptation based on the student performance and the progress. In research, AI can help us in all all research steps and phases, starting from the research questions or research gap, moving through literature review and searching engine powered by AI, then helping in writing, visualization of literature, then helping in summarizing and dealing with PDF files. Data analysis, there are more than one program can be used for data analysis, including developing a new model for prediction, like the machine learning process, collaboration enhancement, and more in research. And actually, this is just a sample of maybe about 50 applications of AI can be used for research. Step by step, and this was generated by a group of our students, which is named AI Secret in Medical Education, and inshallah you will have more than infograph or image like this to simplify the use of AI in medical education. In healthcare, just in rapid, just some titles about using it of healthcare. Based all the use of AI in healthcare are depending on the data. Large amount of data. Yesterday I spoke with Prof. Hussam about the large amount of data and electronic health record that need analysis and need to benefit from data for clinical decision support. In radiology, especially in corona, they benefit from AI in using machine learning to diagnose cases with CT of coronavirus using AI. But we need to remember that the human loop must be there to ensure the correctness and ensure that AI not hallucinated. And we need to remember that two important phenomena, that AI hallucination, sometimes AI hallucinate because we now familiar with the process. It starts by training the model using algorithm, and there is no 100% accuracy for algorithm. So sometimes it hallucinate. And another phenomena, which is the black box phenomena, that we give the input to the computer application, certain mathematical process and formula, and then the output. In the black box, we don't know what exactly happened for the input to give this output. Using data also in healthcare for disease prediction, for also for the personalized medicine, which is like the personalized or adaptive learning. We can tailor a treatment plan based on genetic laboratory data of the patient and the disease progress. And this will be reflected on patient care management, and even using machine learning can be help in drug discovery, as happened also in corona, by discovering or facilitate and expedite the process of vaccine production in corona. Now it is the time to use customized GPT. Customized GPT, it is a tailored GPT like ChatGPT, but it is a tailored to a specific task or specific purposes. I'll give you some example of the customized GPTs I already developed and started to pilot them on different fields: curriculum design, teaching, learning, healthcare, research, etc. But we need to know the difference between generative AI, like ChatGPT, and the customized GPT. In generative AI, it has a large, like ChatGPT, large amount of general data trained on broad database and used for more general purposes. While in customized GPT, I give it a specific data and tailor it for specific purposes, so it will be optimized for particular domain like teaching, learning, medicine, healthcare, research, whatever. Some of them can be used for curriculum design. So I developed a customized GPT used in a specific way for integrated curriculum design. I gave it information about what we need in integrated curriculum, including the hardened ladder, and I can ask it to design certain course up to the 10th or 11th level of hardened ladder of integration, based on the information I gave to it and the course specification. In full exam management, and this is the barcode that you can go to the customized GPT through it. In full exam management GPT, it can help us in the process of developing the exam, starting from revising test learning outcomes, developing blueprint, constructing different test item, and item analysis interpretation. The last is to assess the achievement of learning outcomes. Question bank generator can help us to generate question bank starting from CLOs, analyze it to SLO, starting from the topic of certain course, divide or analyze it to subtopics, and then can generate question bank based on the SLO or the subtopics. For quality and accreditation, I developed a QualiCraft GPT. This QualiCraft GPT, based on certain standard like NCAA or ABET or in Egypt NARS, it can make a review of self-study report based on these standard, and even can help in guidance self-study report member to develop their self-study report. For a student, I developed with my colleague Dr. Ayman Al-Samarnoudi in clinical biochemistry a course to help students to be as a tutor 24 hours, 7 days, to help them in studying and revising clinical biochemistry material. The same for Surgery Monitor, which is for surgery, with one of our colleagues. For research, I have research proposal smart tool that helps students or researchers to develop their research protocol. In clinical chemistry and test interpretation, it is for health care. Through it, we can give a laboratory result, and it can analyze all tests, give summary for test data and differential diagnosis, and even to a management plan. The last for me is a trial version for diabetes prediction in pregnancy, and this one is from one of our colleagues in anesthesia, who developed a customized GPT to assess the need for ventilation. So this is some example of customized GPT. But we need some future direction. We need to start small, collaborate with our colleague in health profession, interprofessional, and in IT, train faculty, and gather feedback. And we need to consider ethical guidelines for using AI, including data privacy, bias mitigation, consider hallucination, and consider the black box phenomena, transparency, and the last but not least is human oversight. We need also to consider cost management, technical integration, and resistance to change, as mentioned by Prof. Hussam and Prof. Boker. What faculty need? They need some competencies related to AI, like digital literacy, curriculum design using AI, data-driven pedagogy, collaboration, AI ethics governance, adaptive learning management, AI-enhanced assessment, and the last but most important is the prompt engineering and the prompt crafting. Also, students need AI orientation, digital literacy, critical thinking, ethical awareness, collaborative AI learning, data privacy, data privacy consciousness, and I think this could be considered as one of the new competence to be added to any framework. My last word, AI enhance, not replace, the power of partnership and synergistic learning. AI learn and we learn for improvement. And this quote not from me, it is from George Couros, who said, technology will not replace great teacher, but technology in the hands of great teachers can be transformational. I can add AI to technology also. Thank you. This is my contact information, and this is my business card. Thank you. Thank you.
Thank you, Prof. Hussain, for this wonderful, insightful session. We shall take questions by end of this session. For this session, I will invite our eminent speaker, Professor Yaver Hayat Khan, who is going to talk about integrating leadership and quality improvement in interprofessional health education. Professor Yaver Khan is Deputy Vice Chancellor at Rafa International University in Pakistan and leading educator in medical education and leadership. With PhD in medical education and master's in health professional education, Professor Khan has developed various leadership programs aimed at enhancing healthcare quality and interprofessional collaboration. He also serves as Director of Center of Excellence in Leadership, Innovation, and Quality at Records in the UAE. Very warm welcome, Professor Dr. Yawar.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very warm welcome and good afternoon to all of you. So I'm honored and privileged to be invited to this prestigious conference, and I would like to acknowledge Jazan University, Saudi Society for Medical Education, and SIMEC Organizing Committee who has done wonders in organizing this wonderful conference. So the topic for my talk is integrating leadership and quality improvement in interprofessional health education. I dedicate my presentation to the beautiful country of Kingdom of Saudi Arabia, which is of course one of my favorite countries, and it's always a pleasure coming here. So these are the contents for my talk. Definition of IPE, I'll be briefly talking about IPE in general, the core competencies, the principles of IPE, the need for integrating leadership and quality improvement in IPE, the benefits and barriers, and then I'll be concluding with the take-home message, inshallah. So, to start with, is a famous proverb that we are basically preparing our students for future, not just for healthcare today. And you know, the future lies in collaboration, it lies in teamwork. We have been listening to the speakers in the morning as well, so they all talked about teamwork and collaboration. So what is IPE? When members of two or more professionals come together to learn with, from, and about each other to improve collaboration skills and patient outcomes, it is popularly known as IPE. So interprofessional education is an important pedagogical approach, and the appealing premise of IPE is that when healthcare professionals, they begin to work in a collaborative manner, the patient care will improve certainly. The World Health Organization, National Academies of Practice, and the American Public Health Associations are a few of the many organizations that have articulated support of IPE. And lastly, the IOM has clearly stated that patients received safer, high-quality care when healthcare professionals worked effectively in a team, communicated productivity, and understood each other's rules. And by the way, we have seen that in the unfortunate times of COVID, when different health professionals, they came together and they worked together for that. There are some examples why we need IPE, and you can see the accreditation councils for pharmacy education, the essentials of baccalaureate education for professionals contained in the standards of programs, Association of Schools of Allied Health Professions. The Commission on Dental Accreditation also outlined standards for both general and advanced education programs in dentistry. And last but not the least, the Liaison Committee on Medical Education. They also have their standards referred to integrating with other healthcare providers. So definitely there is a need to have IPE in our institutions and to integrate it in our curriculums formally as well. So principles of IPE, you can see that they are it is patient and family centered, it is community oriented, it is relationship focused, it is process oriented but outcome driven, it is applicable across multiple professions, and it is integrated across the whole learning continuum. So when we talk about IPE core competencies, basically there are 4 core competencies. They are values and ethics, roles and responsibilities, interprofessional communication, team building, and teamwork. So I think the need of the hour is to integrate 2 key competencies. One is leadership skills, and one is quality improvement. And I will just show you in my next slides why these 2 skills are important for our students to learn. So when we talk about integrating leadership, you can see the evidence-based different articles owing to the importance of integrating leadership in health professional education. You can see over there. So there are different papers which indicate towards the need to integrate leadership in health professional education. So leadership is a very important competency when we talk about IPE, because collaborative leaders, they create an environment where other interprofessional leaders and team members, they feel encouraged to openly and effectively share ideas, contribute to their expertise, and offer feedback. It also promotes a sense of shared responsibility and ownership among team members, and a lot of emphasis has been placed to formally integrate leadership in the interprofessional education collaborative practices. Coming to the integration of quality improvement, again, I have evidence from the literature, and you can see there are many papers that highlight the importance of integrating quality improvement in interprofessional education. And I suppose, in my humble opinion, these 2 skills are very important for our future doctors, for our future generation to learn in order to be equipped with essential tools if they want to lead in future in their organizations. So again, you have seen in my previous slide the need for integrating quality improvement in different IP initiatives. As a healthcare professional should advocate for quality improvement focused training. Quality improvement initiatives should be integrated in the curriculum design, collaborative learning practices, and assessment matrices. However, key challenges in integrating quality improvement in IPE, they include siloed training approaches, limited focus on interdisciplinary teamwork, and resistance to change. So a few benefits of IPE: it leads to improved communication, it increases efficiency, it fosters creativity, it leads to better problem solving, it leads to effective networking, and last but not the least, improved clinical outcomes, which certainly is a key parameter for any hospital-based intervention. So, again, a famous proverb that when I is replaced with we, even illness becomes wellness. We are all aware of that, I think. Sorry, I probably have missed it. Okay. So, the need may be great, but can we move from I to we, and is IPE sustainable? The question is in front of you, and I will quickly highlight a few challenges which leads to hindrance in implementing IPE. So a few important challenges are psychosocial challenges, cultural challenges, logistical challenges, and lastly, structural challenges. So when we talk about psychosocial challenges, there are group dynamics of teams which are challenging, of course. Working groups are always fragile. Health profession students tend to be controlling, and of course, there are defining roles and practices. When we talk about cultural challenges, white coat ceremony we are all aware of, sets medical students apart as special. Faculty, unfortunately, are poorly trained in IPE, and role models are very rare. Peer evaluation remains a challenge till now, and culture and gender are also part of these challenges. In terms of logistical challenges, we have different academic schedules and calendars. We have limited classroom space sometimes. Online curriculum is harder to adapt to IP and teamwork-oriented teaching. And lastly, stretching teaching resources is a precious commodity. In terms of structural challenges, we have healthcare financing, students of widely varying backgrounds and levels of experience, separate leadership, and different funding streams. So I think the time is right for IPE as we sit and speak, and the primary care shortage and healthcare reforms are crises that present opportunities to implement and integrate IPE into our curriculums. So in order to conclude, I would say that as with any educational curriculum, IPE ideally would foster specific competencies in the learner. The competencies include teamwork, leadership, consensus building, and ability to identify and achieve common patient care goals. There is a definitive need to integrate leadership and quality improvement, in particular in our different IPE initiatives. Although there are barriers to IPE, but there is a dire need to develop a specific plan for IPE that includes key elements for optimal success. Take-home message is, it is no longer enough for healthcare workers to be professional. In the current global climate, health workers also need to be interprofessional. And these are a few references from where I was talking. In the end, I would like to invite all of you to another conference of medical education, not as good as SIMEC, I'm sure, but I think half as good as SIMEC. It's a collaboration between Rifa University and International Medical University, Kuala Lumpur, and it will be in October 2025 in Kuala Lumpur, inshallah. So see you all there. This is the initial flyer of the conference, and you can always contact me if you need any information regarding that, or if there are any suggestions regarding my presentation. My details are there, my WhatsApp and my email is there. Jazakallah khair. Thank you very much, all of you, for your patience.
Thank you so much, Prof. Yawar, for this wonderful presentation. For this session, now I would like to invite our next speaker, Professor Fadil Siteko. He's going to talk on developing leadership competencies for effective interprofessional collaboration in healthcare. Professor Fadil is CEO of Academy of Leadership Sciences in Switzerland and a global authority on leadership and emotional intelligence. He is a creator of Siteko Leadership Competencies Model and has published extensively on leadership in healthcare, including words in the British Medical Journal. Professor Fadil has trained leaders worldwide in healthcare, education, and businesses, and he has been keynote speaker at numerous international conferences. Very warm welcome, Professor Fadil.
Assalamu alaikum, everybody. Thank you very much, brothers and sisters, that you have invited me in this valuable conference. I'm very honored to be here and to talk about leadership, the newest insights from neuroleadership, and how can we apply this actually to foster developing leadership competencies for effective interprofessional collaboration in healthcare. So congratulations to a great organization, to the organization committee, and I'm very delighted to hear from the previous speakers how things are being improved in this country and international in medical education. So I will start actually with this as you can see, this publication that we did, and it was a student of mine, so my background is medical education, been teaching for a long time in Switzerland and abroad, and I was supervisor of one PhD student, and he asked me if he could write one position paper about leadership in Islam, and I said, definitively you can do that, and we helped him even to publish it, so with Professor Yawar Khan, but the others, Professor Don and Mariam from USA and so on. and Professor Lumturia Chitaku, and so on. So in the meanwhile, it has been 44 times cited. So we want actually, Academy of Leadership Sciences Switzerland wants to bring the newest insight, especially from neuroscience, neuroleadership, into the market and to spread the knowledge, as Muhammad alayhi salam said. So what I do, I teach brain actually, but I do exercise. I do karate not to hurt anybody because I like discipline, that's why. But we know nothing else can train brain better than sports, by the way. And just to give you this example at the very start, because it has to do with the subject as well. So we want those synapses to be connected. We want those cells, neurocells, to be connected to become better leaders, actually. So we see on the left side, without doing sports, in the middle after 2 weeks, and we see after 2 months, you know, a huge connection between neurons. Couple of words of Academy of Leadership Sciences Switzerland. It has been established as necessity to fill the gap, actually, which it has been, and it is still, you know, of leadership science, because we have a lot of theories, we have a lot of books, but unfortunately, we don't have much evidence-based. So 10 years ago, we have established this academy. It's situated at World Trade Center, Zurich, 5 minutes drive from Zurich Airport. So what we do there, actually, we offer different kind of programs, starting with short courses and workshops till PhD. We do a lot of research because it's a lot of need to do that. And fortunately, we have gathered more than 100 scholars from all over the world who are doing a great job, and we work together. We do advising, coaching, and consulting for individuals, but of course for organizations, institutes, for countries, and so on. We cover all of those domains, as you can see, not to go in details, starting with business, of course, healthcare, where my expertise is in politics as well, law, sports, IT, and innovation. So we are in the process of accreditation of this EDUCA, so-called. It is one of the largest and only one, actually, accreditation body for the continuing education. So we have been a member of Accreditation Council for Business School and Programs in US, and fortunately we got just recognized, and it has been approved, our candidacy. So quality, it's extremely important for us. We are honored to collaborate with many institutes and universities worldwide. We have a great collaboration with RAK, with College of Dental Sciences in RAK, Emirates, and the Rifa University. Many projects and programs we did together. We established together with Professor Yawar Khan that was talking before, actually. We initiated and established the Center of Excellence. And in the meanwhile, we have done many workshops and courses all over the world. So we collaborate with many universities, lately with Northern Illinois University, which we together run programs, Neuro Leadership in Business, very new program, by the way, which I lead. And we have one MOU program, which we work together, actually, MBA in Zurich. We have many courses and programs for medicine and healthcare, which are really very evidence-based, and everything can be applied into the practice. And these are our contacts. Don't hesitate to contact us, because as mentioned, we bring the newest insights from the neuroscience, simplify that everybody can understand it and apply directly into the practice. I've written one book, published 2 years ago, I think, Leadership Competencies in Healthcare. It is 100% evidence-based and easy to understand. Last year, I've written the next book, Neuromarketing, very important book as well, with different kind of guides, and it has ethical principles as well, because we know the brain, you know, people can cheat the brain, unfortunately, and as a researchers, we want people to be aware of that as well. So when we talk about neuro leadership, a new approach, which Academy of Leadership Sciences is being actually one pioneer in this domain as well, it's nothing else except, as you can see, bringing the newest insights from the neuroscience. Nowadays we can, the previous speeches, they were talking actually, how can we develop medical education using the artificial intelligence and so on. So this technology helps us very good to observe the brain, to observe the neurocells, to observe the synapses, to observe even the actually receptors as well. So we see this picture, actually there are synapses here. Some of synapses might die during this talk of some of us, and some new might emerge as well. So it depends the stimulus. Now we see in this picture very good actually how good they are shown here, synapses and even the receptors as well. We see in the next one the sophisticated technology it can make us possible in the life actually directly to see, you know, even those receptors, how they move around. As you can see in this picture here, not only synapses and neurocells, but we can even see the green one over there, you know, the receptors. And what happened actually, where will they dock, in what kind of synapses they will dock. It is an issue of stimuli, and so it shows us actually that we can change the behavior, even though it's difficult. So actually nothing is impossible. As you can see, I visited with my family one museum of Porsche in Stuttgart a couple of years ago. Regarding to this formula, actually the car can drive, you know, on the roof and without falling down. So the another thing, one great innovation that I want to share with you, it is from the scientist, Professor Etem Ramadani, who is doing really a great job regarding health revolution. So we know that we struggle to heal many of the illnesses, unfortunately, and there is a great call actually to combine and you know, this traditional medicine that we do, you know, and why not, you know, applying as well this lifestyle medicine, which really it is now 100% evidence-based and can help people to treat or to prevent illnesses. So this is a challenge for medicine and healthcare to combine, because it doesn't matter at the end of the day for the patient who has treated him. So we can work as a team. This is a subject as well. Want to share with you, you know, this research-based models of leadership, which we can implement actually, and everything evidence-based to enhance collaboration between teams and interdisciplinarity. So we have investigated 6 most developed countries, Western countries I'm talking about, Germany, Switzerland, Austria, UK, USA and Canada, and we came with 63 competencies gathered in 5 domains. As you can see, we got this published in British Medical Journal, so those were countries which we have investigated. So we have published this in British Medical Journal. You come from medicine, you know, to get published there, it's not an easy job, but it has a very rigid research methodology. And in the meanwhile, it has been replicated 88 times actually worldwide. Because of time, I cannot you know, share now everything, but to us it was important to know what are the characteristics of successful leadership in medical education. Do we have any differences between countries, those which we investigated, German and English-speaking ones, and if you have differences between medical doctors and non-medical doctors. So yes, there are data here. Because of time, I'm going to skip this, and because you can read this paper actually, if you like, it is for free. In Google you find this and many others. We didn't have many differences. Just as mentioned, we had actually statistic differences. This I want to share with you. Medical doctors versus non-medical doctors, other professions. And we have in social responsibility, innovation, and justice orientation. Regarding clinics, there has been no significant difference, but statistically, yes, very slightly, as you can see in those parts. This model has been replicated in Latin America because I investigated Western countries. Professor Mano, one oncologist, he was our student at Academy of Leadership Sciences, Switzerland. And we guided him. He has published, he has investigated all actually medical doctors in Latin America, let's say, came with a great start, as you can see. And Professor Yavar and myself, we helped him as well to publish this. And the second model of him, as you can see, it remains the same, but there are shiftings regarding the domains. In previous one, names Chitaku, my name, it was social responsibility at the top. Here we have task management. So it has been published as well, as you can see. We have, those data, as mentioned before. In Asian context, it has been as well. Scientists, I'm talking just about continents now, took the same, and you can see, the data, it was like this. In Pakistan as well, great job. You can see data here. Yes, no problem. 2020, we came with a second model, the third model actually, leadership competency model, Drenica, which as well, it brings the generalizability of leadership competencies. Many other work which we have done, but I just wanted here, actually this year we made the neuroscientific validation of this leadership competency model Drenica. Many competencies that are very important. Because of time, I cannot share with you. Empowerment, extremely important. Integrity and honesty. And here we show, because I want to emphasize again, what kind of neurotransmitters, get involved in different kind of competencies, what kind of the brains are involved. And when we have data, we will convince people that it's easy actually to manage this. And to develop those competencies, we have established actually one methodology, metacognition, which really will tell you, step by step, how can you improve those leadership competencies. So because of time, I cannot go very much in details, but it's extremely important, the development of the brain, what's going on nowadays. I wanted this actually, just to bring those emotions are extremely important in leadership as well. This rationality, prefrontal cortex, it has been over-exaggerated, let's say, and unfortunately we have forgotten how important are emotion in teaching as well, and that's why we have a mess worldwide. So be aware, those are data. Nowadays, they are not soft skills. They are very hard skills. At the Academy of Leadership Sciences, Switzerland, we can prove that. So we have, for example, 50 million bits in 200 of seconds information that come into the limbic system. And we have, as you can see, only maximum 100 bits in prefrontal cortex. What we do actually in teaching, we always try to teach something regarding this rationality, but we seem to have forgotten, the whole brain, respectively the emotions. So non-consciousness, extremely important. Professor Hamdi just brought before, the iceberg. Absolutely right, So many processes that go in brain are non-conscious, and we do decisions like that, actually. So be aware of that when you give feedback to people, so that you start giving something positive always. This I wanted just to show, and we'll end it. So our brain will perceive one negative feedback equivalent to 9 of them. So start always with giving something positive, because until we die, we want actually to remain that we are valuable. I want to finish here with one quote of my son, and I have 3 children, 2 beautiful girls and 1 beautiful son, and we love all together. But he told me once, because I never differentiate girls from boys at all, students either, nobody actually. We are all human beings. Allah made us female and male. He told me, "Father, I give you one advice, build something stable." Because I was playing with him, and the towers which I was making, they were falling down. He told me, build something stable. He was only 3 years that time. We are all here scientists, 1% of the world, let's say. And it doesn't have to be a scientist to recognize. That means one child recognizes what is stable. Investing in leadership, investing in emotional intelligence, you have contributed for a better medicine, better actually medical education, and better society and the better world. Thank you very much, and assalamu alaikum to all of you, and may Allah bless all of you and your families and the whole world.
Thank you so much, Professor Fadil, for this wonderful presentation. So, during this session, we had privilege of hearing from exceptional, thought-provoking presentations and leaders in healthcare profession. Each of them has provided a wealth of knowledge and practical strategies for advancing interprofessional education through simulation, innovation, technology, leadership, and emotional intelligence. As we conclude this session, I invite the audience to reflect on how they can apply all of this knowledge in their practical life. Let us give very warm applause to all of these speakers. And now I would request these speakers to please come on the stage, and house is open for questions. If you have any question, please feel free to ask any question from these speakers. So speakers can come over stage, please. If you have any question, please raise your hand. We can provide you mic and you can ask questions.
Yes.
Yes, please.
Thank you for all the presenters for great speeches. I'm Hassan Zahrani, and I have a question to Professor Yawar Khan. You mentioned in your beautiful presentation online platforms is a challenge for applying interprofessional education. I can argue with that. Some people, they think it's actually an opportunity to implement IPE. What's your input on that? Thank you.
Hello. If you could please quickly repeat the question briefly.
Yes, you mentioned in your beautiful presentation that online platforms challenge for IPE implementation, right?
Exactly.
Some can argue with that and say this is actually an opportunity. What's your input in that?
Thank you very much for the question. I think it's a two-edged sword, and as you said, at the same time it is an opportunity, but at the same time it is a challenge. If you recall the presentation of Professor Boker, so he has mentioned a few things which couldn't be taught online. So there is a need for a face-to-face interaction in that. So similarly, when we talk about interprofessional education, certainly online platforms are an opportunity, and unfortunately the COVID, it has provided this opportunity to all of us. But still, I think in my humble opinion, there are certain areas, specifically in interprofessional education, which over there we cannot teach them online. We have to create an environment where they can work together, and there has to be a face-to-face interaction. This is my take. Maybe you have the right to disagree or agree. Thank you.
Yes, please.
Thank you so much for the nice presentations, all of you. I'm interested in artificial intelligence and also machine learning. I'm Saad Al-Qahtani from the College of Medicine at Najran University. We have started to inject really hot topics regarding AI, machine learning, and also deep learning in our MBBS program at different levels, starting from medical education and research, medical ethics, and finally the applications at the clinical levels. It's a new kind of decision that we have done, but so far it's kind of promising experience, at least in the first assessment of the first cycle of this type of courses. My question now, is there any advice or maybe any comments that will increase the effectiveness, and at least from the point of technical, technical point of view? So this is my question. Thank you so much.
Thank you. Okay. Thank you, Doctor. And first of all, I'd like to congratulate you that you start to integrate AI, machine learning in your curricula. And I think this is an initiative that need to be followed by all of our program, not only in medicine. So this is my first comment. The second, I think it will be good if you can make the study or the integration like a spiral integration of the AI based on the need of the student and then on their preferences. I mean that in the early years you need to give them such an introduction to what is AI, what is machine learning, with special emphasis on its application on their specialty. Step by step, by moving in their study, you can go more depths in integrating AI up till makes, for example, certain electives for how to use machine learning in depth to students who are interested and excited to make this depth. Keeping in mind that we are, especially in the medical field, we are not need to be specialized in as the IT or computer scientist, but we need to have to know and to learn them how to use it, how to benefit of it. And the good news is that even like the customized GPT that I show them to you, it is now become so easy to develop your customized GPT using even ChatGPT. So it is not a need to take long time in training them in sophisticated issues, which may be not in their main business, and but they can benefit from the available technology. So I think go step by step, make it spiral, introduce it, and also the most important to introduce and integrate the ethical use and responsible use of AI in all fields, in teaching, learning, research, in healthcare. By the way, they can use it in responsible way and to consider all ethical dilemma and the issues relating to its use. I hope I give some.
Thank you so much. Quick comment, please. Actually, we are concentrating more on ethical consideration and also how to use it in terms of medical education, rather than have it as, unique specialty or something they have to master before they graduate. No, I think it's kind of something to give them basics in AI.
About ethical use of it in healthcare?
Because they are undergraduate medical students. So it's good to guide them ethically and also to give them a background about how to use it in an efficient way, rather than just take it as, to solve or to do their assignments instead of having it as professional way.
It is related to the ethical use.
So ethical use and how to use it in efficient way in education.
Both are together, but for my humble opinion, it is need to start by the ethical or responsible use. I can give you an example in King Abdulaziz University. We are already developed guidelines for using AI and teaching, learning, research, but in each part we include some section related to the student. For example, I just give an example for the time. For a student, we give them 4 models for using AI. One of them is it is prohibited to be used, like using in writing an assignment. The second one is to use it, but acknowledge in your articles or reviews that you use it and use it for which purpose. The third one, you don't need to write it in your assignment or your work, but you need to consult your tutors or faculty members that you use it. And the fourth one, that is you don't need to disclose or mention if you use it to it. This is as regarding student, and this is one as an example for a student. The same for research. For each step, what is to be done and what is prohibited to be done, like it is prohibited to, not permissible to use it in writing a research or even in writing your hypothesis. So I think you need to start by this. The second, which is to use it, and I think this is an important point, how to use it in efficient and effective way. I think this is need like a workshop for all of us to discuss how to change our teaching method, how to change the assessment method. By the way, they can critically analyze any input, and even you can ask them, use ChatGPT, but after using it, critically analyze the input and tell me how to use it. Start by prompting engineering, how you write this prompt and how you iterate this prompt. By the way, you reach this result or this output. So it is about mindset and about change the behavior starting by us, and this will be reflected on our students.
Thank you so much.
Doctora.
Yeah. Yes, Dr. Muna. We can't hear you.
Assalamu alaikum. Muna Sheikh, Jamiat Imam Abdurrahman bin Faisal. I'm very glad to listen to these talks because they come at a very critical time when both the Saudi Commission and the Dean's Board are revising the framework. So there is a great project by the Saudi Commission where they are actually revising all the competency framework for the health profession in general, and the postgraduate for the specialty and subspecialty. So there are 4 emerging trends that they are trying to incorporate. One of them is interprofessional education. The second one is social determinants of health and social accountability. The third one is AI. And the fourth one is sustainable development of medical education. So I'm really interested in listening to the competencies you have, defined, unless and until we explicitly represent those competencies in our framework, in our curricula, unless we define pedagogical approaches that can reach or allow our learners to accomplish these competencies, and unless we put assessment for these competencies, then we are just putting ink on paper. So I hope that to see that implemented. Another comment for the AI, I just read a paper about how AI can help us as a feedback. It's not yet published, but it's accepted. So there's no ethical thing about it. The beauty, they have done compared the human response to student questions versus 5 chatbots, 5 large learning models. And of course, the large learning models were faster, that we know. They were more accurate, that we know. They were more comprehensive. That's not even, not very surprising. What is surprising is that the response of the chatbots and AI was more understandable by the students. To me, that was surprising. But I think we should give AI a chance. Students love it. Students are ahead of us, and we just need to incorporate it effectively. Competencies for AI have already been defined by ACGME and international competency frameworks. I hope to see explicit definition of leadership, of IPE, and I hope also to include interprofessional collaborative practice. Because sometimes IPE does not mean that we are really practicing it in the workplace. Thank you very much.
Thank you.
Thank you very much, Prof. Mona, for your comments. We have 5 more minutes for any question.
Yes, thank you for the very informative session. I hope you have time for my questions, actually. So regarding the challenges in IP application, I'm Ghada Mjalli, I'm from Princess Noura University. What I'm facing a challenge is I have excellent educators and who are trained in giving feedback, training students. However, I want to train them and ensuring they have the competency to be faculty in IPE activities. So in your experience, what are, let's say, faculty development programs that you observe that are efficient? And do you think if I have excellent faculty, do they take a long time in training and equip them with the skill to be IPE faculty? My second question is a follow-up in the previous answer. You mentioned guidelines for using the AI and prompt engineering. If you can suggest some guidelines that are available in the literature, it would be very helpful to share. And I know there are like some universities or organizations that prohibit the use of AI in, let's say, essays and MCQ, but there are other universities that shows that you can add disclaimers to your output of the AI and you can review it. But if you can share some of those guidelines, it will be very helpful to add them.
About this question is for Professor Husnain.
Yes.
Yes. So she's asking about faculty development program. What do you think that which kind of workshops or trainings can help?
Yeah, I think, thank you very much for the question. And I think the first part relates to IPE, and probably you face some challenges in implementation of IPE. So I think anything that needs to be implemented in any institution, obviously the first thing is the resistance to change. Unfortunately, this is the norm everywhere. But we have to tackle it very, very tactfully and politely, number one. Number two, it has to be a structured approach. I mean, we cannot implement anything right away overnight, so we need to train our people first. We have to shape the culture of the organization in a way that our tutors, our teachers are trained first in IPE, and then they can train the faculty. Secondly, in our institution, and as per Dr. Mona, that the vision of Saudi, the new vision of the Saudi Deans meeting, they are also implementing IPE, and they are in favor of implementing it. I think it's need of the hour, of course, and you have to, again, I would say, first train the trainer. It is very important. Otherwise, if you implement it right away without training the teachers, it will end up in a chaos. So we have, in our institution, we have specific faculty development programs established first. We trained our teachers through those programs, and then we implemented the IPE thing. Lastly, last point is that I visited National University of Singapore a couple of years back, and the thing I loved about them is that right from first year, and Professor Hamdi mentioned in his presentation as well, they just broke the barriers between the basic sciences and the clinical sciences. And they started sending their students from different professions in the community right away, from first year. So they learn how to work in a community-oriented program in the form of a team. And so they definitely had some challenges, but they learned from each other, supervised by a trained teacher who was trained in IPE, and the results were fantastic. So I would conclude that if you want to implement something, it has to be in a structured manner, a structured approach, and most importantly, the ones who need to transfer that thing, who need to implement that thing, they have to be trained first. Then comes the students. Thank you.
Thank you, sir.
I hope that answered to your question.
For your question, thank you. I'll give you just a few examples about what I know about the workshop or the training course related to AI. From nationwide, وزارة الاتصالات, Ministry of Communication, conducted many basic courses which is free and targeted all people in the country over 18 years, and I think all of them, it is just introductory courses for using AI, including prompt engineering. At some university level, like us in King Abdulaziz University, we launched a program which is a fellowship in using AI in teaching, learning, and research, which is all to all faculty members. And alhamdulillah, we finalized the first batch. And in the second batch, there is some seats for external faculty members to join us. At personal level, alhamdulillah, I am conducting a weekly webinar on Zoom, and it is recorded on my YouTube channel, covering all aspects of AI. Till now, alhamdulillah, I finished that related to using AI in teaching, learning, assessment, and after finishing, and all these are recorded webinar. There are about 8 recorded, including one related to how to develop customized GPT. Inshallah, after finishing the exam and by the end of January, I'll start a new course of 5 weeks related to using AI in research. So this is available, inshallah, either through Zoom or recorded on my YouTube channel. Thank you.
Thank you so much. We understand that there would be many questions. We can take last question because we are running short of time. We need to move next.
Assalamu alaikum.
Quickly. Yes, please.
I want to ask Prof. Muhammad about, you know that there is inherent biases in the AI models, okay? So what are the steps to prevent these biases when implement AI models for learning?
How to use the bias?
Aye.
Okay. The bias, or as we mentioned, the AI hallucination or the black box phenomena are well documented phenomena for all AI application. So you need the only solution for this is to verify you yourself, to verify any output come from it. Or you can use your own developed machine learning process, which is more complicated, but even you will have also a chance for inaccuracy or hallucination, which is also well documented and well known. But what people start to do, especially in something related to healthcare, is using your own data, using your own servers, and using your own programmer, which is a costly process and need more time and experience. But by the end also, it is not a guarantee that there is no bias. Till now, I'm not sure about what will happen, inshallah, tomorrow in this era and with the development of AI. But this is, for my information, till now, the only way to combat bias and hallucination is to verify any information come from any AI application. And like I mentioned in ChatGPT may make mistakes, so check important information, and this is applicable to any AI tools or application.
Thank you so much.
Again, another question for Dr. Yawar.
We are running short of time, so probably you can catch him later on. That will be really wise. So thank you so much to all speakers. Thank you so much for wonderful audience, for your active participation, and let's give big hand to all of these speakers. And thank you so much and enjoy it.
No, have a seat here, please. Dear Professor Fadil, and we need you here on the stage, actually, to honor you. Thank you. Can you come here? We are honored to invite our keynote speakers to be actually honored for their presentation, for their wonderful presentation. And we would like to thank all the attendees here. So we invite the Vice President to come to the stage, the Vice Dean for Academic Affairs in the Medical School, Dr. Isa Adawi, and also the President of the Saudi Society for Medical Education, Dr. Hassan Al-Zahrani. So our first speaker is Professor Muhammad Hassanain. Second keynote speaker in this session is Professor Yawar Hayat Khan. Thank you. The third keynote speaker is Professor Fadil Sitako. Thank you. We would like to take the opportunity also to thank the Vice President for Academic Affairs, Professor Muhammad Arishi, for being here to listen to our speakers, since he has a health specialty actually. So I think he's enjoying our conference here. So thank you all for being here. We will go to a break till 4 p.m. Then we will start our oral presentation for the first session, from the first presentation till the fourth presentation. Each one of those presentations is 10 minutes with 5 minutes of discussion after the presentation immediately. And we will finish our program tonight as 5 p.m. Thank you all for being here. At 5, yes. We will come back at 4, yes. خلاص دكتور حسن.
Hello there. It is my great pleasure to continue the activity for this day, and I would be happy to be the moderator for the oral presentation. Our first presenter, Dr. Asma Abdel Nasser. Dr. Asma is Associate Professor of Medical Education, Director of the Health Professional Education Center at Ibn Sina University, Ibn Sina College of Medical Science. Please, Dr. Asma, come to the stage. Each presenter will have 10 minutes. Then if you have questions, keep it for the end.
Hello everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. My topic today is about evaluation of an online interprofessional education course in ethics and professionalism, experience from medical, dental, and pharmacy students. We are declaring no conflict of interest, and this is research work published in Frontiers in Education, and this is the collaborative authors of this project. Actually, in the introduction part, we need to know that health professions are confronted with complex ethical challenges, and they are always expected to demonstrate professional behavior in dealing with these challenges based on different standards. Therefore, medical ethics and professionalism are fundamental pillars in healthcare practice, and ethics and professionalism in the healthcare reflect how health professions behave during their practice. Health profession institutions have implemented various strategies for teaching ethics and professionalism, including using interprofessional education strategies. At Ibn Sina National College in Jeddah, Saudi Arabia, has recently introducing a core course in ethics and professionalism, actually from 4 years ago, and it is for undergraduate medical, dental, and pharmacy students. The main goal of this course is to provide the future medical, dental, and pharmacy students with the foundational knowledge in identifying, analyzing, and managing the most common ethical issues and dilemmas in their practice. The course is taught through using an interprofessional context and was initiated as an online course during the academic year 2020 because of the COVID-19 crisis. Our study aimed to evaluate the different aspects of this online course in ethics and professionalism from the student perspectives, in addition to exploring their viewpoints regarding the importance of learning ethics and professionalism in undergraduate curriculum, as well as their attitude toward IBE with other healthcare professions. The study design was using cross-sectional questionnaire-based design, and the course, which is including both theoretical and the practical component, taught through interactive lectures, case-based learning session, and student-led webinars and discussion forums. Students from the 3 programs in the 4th year, medical and dental and pharmacy, are introduced through this IBE course, and we using an online platform through learning management system named DigiClass, embedded with or integrated with Microsoft Teams. Our sampling was, we are targeted all the students who studied this course, so we use comprehensive sampling technique. 190 medical students, 27 dental, and 33 pharmacy. We use a self-administrated online questionnaire, which is developed and revised by the research authors, and we did some validity studies on this questionnaire. It consisted of 31 items and addressed different aspects of the course, as well as IBE learning strategies and the importance of using ethics and professionalism. The questionnaire, using a 5-point Likert scale, ranged from 5 strongly agree to 1 strongly disagree. In addition, that this questionnaire containing items to explore the demographic data of the responder, gender and study program, as well as brief introduction about the aim and the importance of the study, and informed consent from the participant to share in the study. The questionnaire was constructed by the authors, and we did some reliability and validity study to guarantee its validity. We're using content validity through reviewing by experts in medical education, also phase validity through piloting the questionnaire through the students, and we excluded the responses from the sampling. Plus, we do constructive validity using exploratory factor analysis. The research work taking IRB number from Ibn Sina committee. Regarding data analysis, we did using different statistical data analysis, and also we did exploratory factor analysis for validity of the questionnaire. The results of the study divided into 2 sections. The first one related to reliability and validity of the questionnaire. The reliability we using Cronbach alpha, and it demonstrated that the coefficient of the questionnaire 0.93 with high level of internal consistency of reliability. Also, we did construct validity for the questionnaire using exploratory factor analysis, and this factor analysis revealing that this questionnaire 31 items divided into 3 main factors. As it is appeared in this table, we have 3 factors. Number 1 related to the course evaluation, and factors number 2 related to the perception of the student toward IBE, and factor number 3 is the importance of using ethics and professionalism for healthcare students. Section 2 related to the analysis of responses of the study participants, and the response rate were 86.3% of medical students, 75.8% of pharmacy students, 66.7% from dental students. And in regarding this part, we did ANOVA study and to comparing the 3 sub-themes of the questionnaire: course evaluation, perception, and importance of ethics, and we did ANOVA study to compare between the medical, dental, and pharmacy responses of the student, and these results revealed that there is a statistically significant difference between their opinion. So we need to know that, we need to conclude that this course was initiated by using IBE in Ibn Sina as a novel concept in Middle East and North Africa region. The student reported their experience with the course from 3 aspects, which are perception about the course, and the perception about IBE, and the perceived importance of ethics and professionalism. Overall, the participants expressed positive evaluation of the course, highlighting its organization, content relevance, instructor effectiveness, contribution to their understanding and development of professionalism and appreciation of IBE. The results of IBE course that the student reported improvement in their teamwork abilities, understanding of ethics and professionalism, enhanced communication skills, and increased respectiveness of interprofessional context. Regarding the perceived importance of ethics and professionalism, the students show positive perception, as well as this might be attributed to the vital role of using of ethics and professionalism in their professional career. So in conclusion, the positive perception of online IBE course in ethics and professionalism expressed by our study participants. Also, these findings support the integration of similar courses into health profession curricula by incorporating ethics and professionalism education through IBE. The development of competent and ethical healthcare professionals can be fostered, ultimately improving patient care and patient outcomes. There is some limitation for this study, which the first one, it is included and which be considered in the future research, that the questionnaire didn't tackle the perceived challenges for IBE by students, and not all health profession students were included, such as nursing students, because actually until now this course not implemented for nursing students. But in the near future, we are introducing the same course for all professions inside the college. Also, the study measured only one level of evaluation of the educational intervention model. In addition, this is a descriptive cross-sectional study. Other factors that might have accounted for the difference between the students of different programs remained unexamined. Moreover, data collected through questionnaire might be subjected to response bias, and depth qualitative data would have been useful for a triangulation of evidence of the student perceptions. This is the reference of our study, and this is my contact information. Thank you, Doctor.
Thank you very much, Dr. Asma, for your adherence to the time. Our second speaker will be Dr. Dalal. She's a medical student from Bisha University. We always encourage our students to present and to participate and to change opinion. And this is a message of interprofessional education. So even your presence is highly appreciated, and we encourage it. So Dalal, come to the stage.
شكرا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. My name is Dalal Muhammad Al-Huyan. I'm 6th-year medical student at Bisha University. First of all, I warmly welcome everyone here today. I thank Jazan University and the organizers for hosting this wonderful conference. Also, I thank Bisha University and its leadership for support and encouragement. So, I'm blessed today to present my research title, Transforming Medical Education, the Role of Artificial Intelligence in Medical Schools, and the Need for Curriculum Reforms in Saudi Arabia, a systematic review, presented by me, Dalal Muhammad Al-Huyan, and my supervisor, Dr. Hadi Miskin. At this moment, I would like to thank my research team for hard support and dedication, especially our Dean, Dr. Ahmed Al-Amir. So, artificial intelligence is becoming essential in medical education, helping to improve learning and clinical practice. In Saudi Arabia, artificial intelligence supports the educational reforms of Vision 2030 by preparing healthcare workers with the skills they need. For example, artificial intelligence proved its value during the COVID-19 pandemic by transforming healthcare system. However, to fully use artificial intelligence in medical education, we must overcome certain challenges to achieve these goals. So, this is a systematic review aims to assess how artificial intelligence has been integrated into medical school by looking at its application and challenges to inform the planning of the changes, and how to use the recommendations of this study in the Saudi medical schools. So, my thoughts about the big question. How can the integration of artificial intelligence technology into medical education curriculum in medical schools enhance learning experiences, better clinical skills, and prepare students for a future career in medicine? And what are the necessary curriculum reforms required to facilitate this integration? About the population, we have population are medical schools, intervention, artificial intelligence integration in the curriculum, comparison traditional medical education methods without artificial intelligence, and the outcomes of this study, improvement in medical educational outcomes, including learning experiences, better clinical skills, and readiness for future careers in medicine. About the research strategy, we have two main research concepts in this study. First, medical school, artificial intelligence, and the traditional medical education. Second, learning outcome and curriculum development. This is the prisma of this study did by using confidence. About the identification, we have 544 studies, screening 505 studies, excluded 443 studies, and in the final analysis, we have 9 studies. So, we have 9 randomized controlled trials study from PubMed and Embase, focusing on research question from 2021 to 2024. So, these studies demonstrated that artificial intelligence tools like ChatGPT, virtual operative assistants, and iSIMs enhance learning outcomes in medical and surgical education. Artificial intelligence enhance diagnostic skill, surgical performance, and critical thinking. Tools like illustration device and LearnGuide also improve communication and mentoring. So, artificial intelligence transforms education by offering more effective alternatives to traditional learning, teaching. So, in conclusion, there is a growing optimism that Saudi Medical School will benefit significantly from artificial intelligence, supported by its continued educational use and positive perceptions. However, addressing infrastructural and ethical challenges is essential for its successful implementation. Transforming educational content is an urgent priority, requiring collaboration among all stakeholders in education and technology development. These efforts aim to enhance medical education and prepare the healthcare system to tackle national challenges using artificial intelligence. In suggesting necessary curriculum reforms, first, incorporation of artificial intelligence courses, including machine learning, data analytics, and application in medicine. Second, interdisciplinary approach. Third, ethics and humanities integration. Fourth, continuous professional development. And fifth, investment in technology infrastructure. By implementing their reforms, medical schools can effectively integrate artificial intelligence in curricula. preparing students to become competent and ethical practitioners in a rapidly evolving healthcare landscape. And thank you so much.
Thank you, Dalal, very much. You spared 2 minutes for us. We'll add it to discussion. The third speaker will be Mohammed Usman Andrawi. Mohammed Usman is Assistant Professor of Histopathology and Medical Education, College of Medicine, King Khalid University. Mohammed Usman recently finished his Master in Medical Education from Dundee. Please, Dr. Mohammed, the microphone for you now.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. My topic today is the metacognitive skill level and its impact on academic performance in undergraduate medical students, a cross-sectional study at King Khalid University. I would like to present this topic on behalf of my esteemed colleagues, Mrs. Safa Andarawi, Faculty of Medicine in Charles University, Sharjah, and Dr. Hassan Otaifi, King Khalid University College of Medicine in Abha. I will begin with a definition of the term metacognition. Metacognition is the awareness and control of one's own thought process, and it is essential for effective learning and problem solving. In medical education, metacognitive skills enable students to self-monitor, reflect, and adapt their learning strategy, potentially enhancing their academic performance. So these are elements of the metacognitive, some of the element of metacognitive. The students actively track their understanding and progress, and then reflect and analyze their learning experience to improve their performance, and then they adapt and modify their approach and methods for better outcome, and then hopefully they will achieve better academic results. And this circle continue on the same way. The aim of this study is to evaluate the metacognitive skill level of medical students at King Khalid University, and to determine the relationship between these skills and their academic performance as measured by GPA. So the assumption here is that if a relationship was found or is found between the metacognitive skills or metacognition skill and the GPA, this would give us a tool for enhancing the academic performance. Methodology. This was a quantitative cross-sectional study conducted among 143 medical students at King Khalid University through an online questionnaire, through a website, professional website for questionnaire called onlinesurveys.com. metacognitive.ac.uk. And the data were collected using the Metacognitive Awareness Inventory, MAI, invented by Flavel 1975, contain 52-item questionnaire assessing knowledge and regulation cognition. And the GPA were obtained from university records. The metacognition inventory contains or include two main domains: the knowledge of the cognition, and the second domain is the regulation of the cognition. The first one, the knowledge, contains subdomain declarative knowledge, which is understanding facts and concepts about one's ability and strategy. And the procedural knowledge is the awareness of how to effectively use strategies during learning. And the conditional knowledge is the understanding when and why to adapt strategies to certain contexts. The second domain, the regulation of the cognition, include 5 subdomains. Planning, the ability to set goals and choose strategies before tasks. Information management, techniques for processing and organizing information effectively. Comprehension monitoring, tracking and adjusting understanding during learning tasks. Debugging strategies, identifying and correcting errors in thinking or learning. And then lastly, the evaluation, the assessing the effectiveness of the strategies and performance post-task. And this circle goes on the same way. The result shows a statistically significant positive relationship, albeit modest, between GPA and most aspects of metacognition, including the two main domains, knowledge and regulation, separately, and the overall total 52 scored, the knowledge plus regulation collectively. This diagram shows the statistic for the domains of the metacognitive inventory. All of these shows significant relationship, except those under the red arrows, the declarative knowledge, information management strategy, evaluation, and planning. The coefficient relationship or correlation is weak, as shows in this diagram, because as you can see, it ranges between 0.243 and 0.155, which indicates weak positive or weak relationship. Type conclusion, the study indicates a positive relationship between metacognitive skills and academic performance among medical students, and suggests incorporating learning strategies and academic outcomes. So the justification for the weak correlation between GPA and cognitive skills is that the academic performance is affected by other factors other than cognitive skills. So this will not underestimate the value and effect of the cognitive awareness and skills on the academic performance. So the recommendation here of this study, number one, integrate metacognitive training, like workshop, self-monitoring, reflection, and planning strategies. Focus on key subdomains like declarative knowledge, conditional knowledge, comprehension, monitoring, and debugging strategies. Personalized support provide targeted intervention based on student-specific metacognitive weakness, promote reflection using reflective journals and feedback loops to improve self-regulation and awareness. Number 4, expand research to explore other factors like motivation, mental and physical health, environmental, social support, and prior knowledge, which these are known to affect the academic performance, to evaluate these along with the metacognition. Also, the sample size suggested to increase to upgrade the value of this study. Longitudinal studies assess metacognitive development over time for deep insight. Active learning incorporate problem solving and case-based learning to enhance practical metacognitive skills. Faculty training equip educators to foster metacognitive growth in students. These are the main references related to this topic. I am looking forward to cooperate with anybody who has the same interest in making studies about improving the academic performance for the students. So this is my email for contacts. Thank you very much.
Thank you, Dr. Andrawi. Also, you spare 1 minute for us. We'll add to the discussion. The fourth presenter is Professor Professor Said Imran. He's a professor in medical education, Northern Border University. Please, Professor Imran. He's not there? So, if he's not there, we'll go to the fifth presenter to save time. So, the fifth presenter is known to you all, Dr. Shaza Iqbal. Where is Shaza? Shazia, sorry. Where is Shazia? Not here? Shazia. She's around. I saw her a few minutes. Sorry, Shazia for tomorrow presentation. So may I call on the all presenter to come to the stage and to receive question from the audience. Dr. Asma, Dr. Dalal, Dr. Muhammad Usman. Please. Do you have any question? Do you want to add? Do you want to comment? Yes?
Assalamu alaikum. Thank you so much for your interesting presentations, all of you. I'm Saad Al-Qahtani from College of Medicine. My question will be for, if you remind me your name, sorry.
Your name, Dr. Dalal,
Yeah.
Dr. Asma,
Dr. Asma. Interesting presentation regarding interprofessional learning. But I mean, at least to my knowledge, I think what you have presented, it's something really not ideal for interprofessional learning. I mean, scientifically at least. So I think interprofessional learning focusing mainly on skill and competency based So I remember when I was during my study in Karolinska, we had a department of orthopedics collecting, there were medical doctor, surgeon, physiotherapist, nurses, etc. So, and the main goal was to achieve different skills at different level, different also type of professions. What I have understood from your presentation that you had one topic regarding ethics and professionalism, and the only applied side of the interprofessional learning was having different students or different specialty or different professions. But I mean, maybe it was kind of theory, absolute theory, away from skills or applied skills. Can you elaborate on that, please?
Okay. Actually, thank you, Doctor, for your nice question. The course is built upon using different educational strategies. We are using plus, I agree with you, there is theoretical knowledge to build the knowledge related ethics and professionalism. But besides this part, we have some educational activities like we're using student-led seminars. These seminars done by IBE teams from different professions students. They are collaborating together to solve a certain ethical dilemma. Also, we also using projects. We ask the student to do some kind of educational campaigns related to many ethical dilemmas, and they did these campaigns for the public and community, and they are delivering different point of view from different professions in relation to this certain dilemma. I agree with you, IBE are used in clinical context more, but no harm if we introducing IBE from doing some kind of early exposure, because you know when the different professions learn together, they can work together. This is the IBE slogan, always said that. So IBE can be started from the primary phase as an exposure for the students, then later on into their clinical context. No problem.
Thank you so much. Actually, I was not opposing what you have done, but I mean, because we have kind of challenges to initiate IPE, for example, at our institutions, because we have, kind of different programs, different colleges, and even different program learning outcomes. So, I mean, to have one designed course about IPE, we need at least to unify some of the PL laws in different programs. We need to, I mean, it's kind of, big challenges, especially for those programs taught to students in discrete way. So without any kind of coordination or collaboration between different specialties. Thank you so much.
Thank you.
Okay. Asad.
I want to
Assalamu alaikum. Really nice presentation for all the presenter. I wish you best luck. I will ask a single question regarding Dr. Dalal about the artificial intelligence. The role in this era about artificial intelligence, now it is, nobody can keep silent about that. You suggest in the end of presentation that there is a necessary change, reform for curriculum. So which part of the curriculum should be reformed? And if we can categorize the areas that need reform, which one should be urgent and which one should be delayed, if it can be categorized? Thank you.
Thank you so much for this question. About the necessary curriculum reform, like I said, first, you should change the incorporation of artificial intelligence in courses, integration of humanities, ethicals, transformation of and development of the curriculum in every medical schools in Saudi Arabia. And thank you.
Thank you very much. I have a question to the wonderful student.
Yes, Doctor.
She's a student, right? You're
Yes.
a student.
Yes.
I'm very happy that you have used a systematic review and you have followed the structure of doing systematic review. That's very nice. I want to ask you, how do you use artificial intelligence as a student? Forget about the systematic review.
Okay.
How the students learn in 2025? Can you comment?
Okay.
How they learn? Honestly, I don't know. So I want to listen from you. How do you learn, and if you are using artificial intelligence?
Thank you, Doctor, for this question. Actually, I use artificial intelligence, especially ChatGPT, in all things in my life, in assessment, in thinking with me, and chatting with me, maybe. It's so fun. It's so artificial intelligence give more information, give more idea to make brain more proud. Yeah.
Wonderful. Well, so there is no need for the faculty. I think the deans have to reduce the number of faculty. May I ask another question to Dr. Sana? Dr. Sana, and as a follow-up, Asma, as a follow-up of the question about the course itself. So my understanding, it's a course which was given to the different health professional students, and they are following it or learning from this course, and then you did a sort of a questionnaire, getting their feedback. So they are not communicating with each other.
Again, Doctor?
Are they communicating with each other during the course, or each one is going through the course, learning from the knowledge in the course? How it was done? The course, not the research.
Yeah, I'm agree with you. Okay. Thank you for your question. The course itself conducted through two components, many components. We use different educational methods. We have the theoretical component conducted by the educators who delivered the knowledge regarding ethics and professionalism, and other component part depending on the student learning strategies. We ask the student to do kinds of student-led seminars regarding ethical dilemmas like abortion, ethics in abortion, and also like ethics in research. Many dilemmas, ethical dilemmas like this, and also regarding dangerous state, many topics. And also we divided the students into IBE teams, and these IBE teams requested to deliver educational campaigns to the public. And also we did many campaigns in different medical schools for as a kind of collaboration. So the students themselves do teaching for each other through these campaigns, and they are a team from different professions. So they learn and they collaborate together. There is the learning from each other during the course and interaction among each other.
Thank you.
More questions?
Assalamu alaikum. Just I have a question for each one of you, starting by Dr. Asma. Do you include any qualitative question, I mean open question in survey, just to address how much the student benefit from this course? If so, what are these outcomes?
Actually, the questionnaire, all items of the questionnaire, quantitative, not qualitative. We didn't want any open-ended question.
Use a mic.
Okay. Sorry. Thank you, Doctor, for your questions. The questionnaire is containing 31 items, and all items are closed-ended questions. You know, the responses from the students always, for the qualitative part or for open-ended question, not so much, but we get some kind of feedback, personal feedback from them. And this feedback also through the course survey, which is done regularly through a quality department. We use this survey and their responses for the improvement of the course. Yani the current course not looks like which is implemented online. Now the course is completely on site, and there is more interaction and more face-to-face work rather than the one conducted during the COP.
Okay, Dr. Asma, I have a question for Dr. Dalal as well as Dr. نعم منداوي نعم Dr. Dalal. Regarding the BICO question, I noticed that your question was about artificial intelligence in the curriculum, isn't it? And the population is medical schools.
Yes.
Is it restricted to the Saudi Arabia or over all the world?
In Saudi Arabia.
In Saudi Arabia.
Yes.
So you have at the end of the research, you got 9 studies, isn't it?
9 studies, yes, randomized control trials.
Just to clarify this point. Thank you.
Doctor.
Yeah, thank you. My question, Doctor, regarding the metacognitive assessment or measurement, also it is like abstract things, I know, and it includes a lot of soft skills inside. Since you used valid questionnaire. Do you did any analysis that to make sure that the reliability of the questionnaire is still good?
Actually, the inventory I use, it was invented too many years ago, but it was tested in validity and stability. In the Chromebox Alpha, it was 0.9. Okay, and it is being used till this year. There is a paper also use the main inventory, so it is valid and stable.
Yes, Dr. Nada? If it is not functioning, you can come to the stage, no problem.
I was about to ask the same question. Actually, your question contained about 51 questions, and as a student filling that form, it might be a little bit hard task. Although it have been tested, but I can't imagine a student filling 51 questionnaires in the same way. So I was about to ask the same question. Do you can have other modality of assessing the same, like a focus group discussions with the student? Could we get a similar result with much more easier? This is number one. And the second question is asking about megacognition at the level of the faculty. Have you assessed their knowledge, how they use it before in similar study? Thank you.
Your question to Dr. Dalal?
Dendrawi, all Dendrawi.
Huh?
Yes, to Dr. Dendrawi.
Yes. Okay. So I didn't get the first question, but
the first question, Dr. Nada. Dr. Nada, repeat the first question.
طيب.
The question in line with Dr. Majid, I note that your questionnaire is contain 51 items.
52.
Oh, 52, sorry, 52 even. So I think it's from medical student point of view, it's going to be a lot of questions going through them. Yeah. So it's going to be a little bit hard task for them to fulfill it, especially nowadays a student. Yeah. Although it have been, you mentioned the validity of it, but it's a little bit difficult. So did you think about a focus group discussions rather than these questionnaires, or you prefer it because it's validated? This is number one. Number two, the faculty awareness of megacognition, and have they used it before? Have you tested or have done a similar study in this area?
So the first question, there was a concern about this long question, and if the students will respond honestly on this question or not. But we don't have another way to measure Yani other than this, even though there is some question about if they just take it out or they honestly, but before we give them the questionnaire, we introduce to them the idea of the metacognition, okay, and importance of response honestly on all questions, and we promise them that we will provide them with the results of this study and give them guides for improving their metacognition. So to encourage them to respond to the questionnaire honestly. The second question, this is the idea which I am looking forward to assess if the faculty have the idea of metacognition. Maybe some of them have it, but they don't know this is a metacognition. They practice, but they don't know it is a metacognition and its importance on the academic performance. So one of my recommendations here is the equip the faculty staff with the strategies for knowing themselves about the metacognition, and then to try to implement the methods on teaching to improve the metacognition in the among the students.
Just have a minute. Okay, thank you. Just a comment and thank you. Thank you, Dr. Muhammad, Dr. Asma, Dr. Dalal, for your wonderful presentation. And special thanks for Dr. Dalal, actually, because you and your colleague did your homework about the use of AI. And it is now, as we mentioned in Arabic, القرى في ملعبنا. And it's our role as an educator to start to study the result of your study systematic review and start the process to discuss how is the curriculum to be changed and what this change can be done to integrate AI. So thank you very much, Dr. Adela.
Welcome, Doctor.
I'll go now to Dr. Dalal. I think, thank you so much for sharing your study, but I mean, my question, maybe it's not really directly to your study or to your research. I would like to hear about your opinion as a student or undergraduate students. In which part of your study you would like to see or to have AI as, you know, kind of tool to help you in studying? I mean, feel free to answer it, and I mean, from your point of view.
Thank you, Doctor, for this question. Actually, artificial intelligence, it's more effectively in medical students, especially in surgical skills, like any surgical procedure, any surgical procedure, anything in surgical concern, we can use it, artificial intelligence, and improve the skill of the student.
So, I mean, from another perspective, I mean, do you use AI, for example, to summarize something really difficult for you? I mean, if you get the presentation from your tutor or maybe lecturer, and then you upload it to AI to get it summarized. Yes. Is this one of the things you use AI for?
Yes, Doctor. All students, or all medical students, use AI to summarize all lecture in College of Medicine, to make more multiple choice question, to make more short answer question, to facilitate this educational السيرة التعليمية يعني.
So as a conclusion, even to us as faculty members, I think AI now should be taken seriously. For example, I mean, most of the students, they use AI from the negative side, or maybe just to complete their assignments, to use it to get the right answer, for example, for any one of the questions during the examinations. While still, I mean, I think AI and other related topics can benefit the students and give them more easy way to study. And I think as Professor today introduced many different platforms for AI, and how can we capitalize on and use them in the learning and teaching process. Thank you so much.
Thank you.
In fact, as a moderator also, I need to take this chance, not to go without asking. I need to ask Dr. Mohammed Usman, what factor could affect the metacognition apart from the student? How could the metacognition reliability and validity affect it? For instance, if the teacher is very strict, how could affect the process of thinking? And if he is a little bit, I can't say loose, but if he, offer the student a safe environment, they might think properly. So what is the factor can affect the metacognition? Mohammed.
I think, from my opinion, this all depends on the personality of the students themselves. The distinguished students may overcome the other many environmental, social, and other things by their metacognition itself. So it is kind of loop inside. The metacognition itself depends on the personality of the student himself and how he will overcome the other factors affecting the academic performance.
Thank you very much. Still, we'll give chance if there is few questions. But I think the surgeons today are happy because the student, they mentioned that they enjoy surgery by AI. Any more comment? Okay. Okay, and then your chance after.
Thank you.
Here? Okay.
My name is John Gilbert. I'd just like to congratulate the three of you. Very thought-provoking. And I think I'm going to go away kind of contemplating the complex questions that you actually posed for me even after 60 years. A comment on the problem of ethics. This is, I think, the oldest topic that we've ever tried in interprofessional education, and is still a problem. I think what we don't know is what are the downstream effects of actually conducting programs like this, and what do our ethicists contribute to looking at those downstream effects. That's not a question, it's just an observation. My observation is about AI. We use it a lot. I'm very concerned that it is the English hegemonic. Virtually every large language model that's been developed has been developed using English. I'm very, very concerned when I go to other parts of the world to realize that the culture that is being promoted is an English language culture. And I think one of the things that we will have to think about very seriously as we move forward is, what do we do about tone languages, for example? What do we do about Arabic? How much stuff is there to put into a large language model in this language at this time? And what does that do to a culture? As I say, it's not a question, it's just an observation. And I think it's one we should all be considering all the time. Thank you very much again for your very interesting contributions this afternoon.
Thank you.
Any comment for his comment?
No, I don't have a comment.
So it is, anybody want to respond?
Comment.
Okay. Last before the last.
One last question, I promise. Dr. Dendarawi, you said that you have introduced your students to metacognition in advance to send the questionnaire for them.
Yes.
Don't you think this will affect your kind of results, or I mean the real assessment for the students regarding your research?
Yes, I think so.
Thank you so
but,
much.
But actually I did the both to counteract the effect. Some of the students, after the lecture, I gather them in a room and I say to them, please, I have a questionnaire, okay? I would like you to fill the questionnaire here in front of me. Okay? And as I said, I give them the introduction about the metacognitive and the benefit in academic performance and the grades. This is stimulate the students always higher GPA and promise them with the result and methods to improve their metacognition. That way may counteract this effect of this negative.
Excellent.
Yes.
You could have started with, for example, asking them about metacognition and also the different aspects of metacognition, if are they aware about it or they don't know it, at least by definition, in advance to go to your questionnaires. Thank you so much, anyway.
Thank you.
Thank you very much. I would like to convey my appreciation. I thank for the presenter. They are very elegant, very nice, very interesting, and for the audience, very nice question, very interesting comments. Really enjoy it, and stay well. This will bring us to the end of our activity today. So meet you tomorrow. Go home, enjoy Jazan time, enjoy the sea, enjoy the winter here and everything. Thank you very much. Thank you.
Thank you.
تمام يا دكتورة. دراوي. تمام.